morning, everyone. My name is Kitsada Buddhikhan from Chulalongkorn University. Here I have Professor Wang from National Cancer Center, Singapore, who will co-chair this session on CAR T-cell in lymphoma and myeloma. As everyone knows, over the past several years, CAR T-cell therapy has transformed the treatment landscape of relapsed/refractory hematologic malignancy, especially B-cell non-Hodgkin lymphoma and multiple myeloma. Today, we have 4 experts in the field who will share their experience and visions on this rapidly evolving topic. I would like to introduce the first speaker, Professor Duan Du. Professor Du is the Chief of Hematology and Director of Myeloma and Lymphoma Cancer Center at Shanghai Changsheng Hospital in China. Her research interests focus on plasma cell disorders, in particular high-risk multiple myeloma, IgD multiple myeloma, and CAR T-cell therapy. She is a very active principal investigator working on more than 20 clinical trials. Please, Dr. Du will give us a talk on CAR T-cell therapy in multiple myeloma.
We're honored here to present CAR T therapy in multiple myeloma. I'm Dr. Duan Du from Shanghai Changsheng Hospital, China. There are 2 parts in this session. The first one is Asian update in CAR T for multiple myeloma. The second one is CAR T therapy from clinical study in China. Even though many recent advances on cancer novel therapies, researchers have yet a long way to cure cancer. It seems that recently development immunology therapy-based therapy approaches, such as CAR T, which has been taking a great step forward in cancer immunology therapy, especially in multiple myeloma. This is a recent review shows that many antigen targets has been optimized in clinical study for multiple myeloma. And here shows all the program, how to prepare the CAR T and how to transfusion back to the patient's body. Here the structure of the CAR T and how the CAR expression in T cell, which are made of the antigen binding domain. This is usually a single chain variable fragment, but maybe have the different structure. The antigen binding domain is followed by hinge and transmembrane domains that connect the antigen binding domain with the intracellular T cell signaler. That could be both the co-stimulatory domain, such as the CD28 and 41BB, and the T cell activation domain that is adopted from the CD3 zeta. Here representations comparing a monospecific CAR T transfected T cell with a variable different strategy for targeting 2 antigens simultaneously. This table summarizes the study from selected clinical trial of the CAR T cell products. There are so many clinical studies, including phase 1 and phase 2, also phase 1B and 2 study. And from all this study, they show the kind of a similar result. If we compare the response rate, such as PR or better or CR or better, from the different study, they show the very high response rate is over 60%. And even for the CR or better, some studies just can achieve the 80s. And all the study has showed is very high and very deep response rate. From the clinical trial website, there are 136 studies around the world. Among them, there are 68 studies are in East Asia, especially 63 from China. We can see this field is very active. It's a very activity in China. Next, I would like to introduce the CAR-T study from our center. This study design, the study since the 2017, there has 3 centers enrolled in this study, 32 patients from our centers and 15 patients from another 2 study centers. From all the program, we can see all the patients like the similar inclusion criteria and similar exclusion criteria. But the one thing I need to mention is just in this study, because some patients has a very bad performance, but all these patients has no other option. So this study we made the compassionate used. We can call it expanded assessment used. Because we know for the CAR-T trial, strict inclusion and exclusion criteria, clinical studies often do not address the challenge presented by non-trial populations. So patients with poor performance status, especially at the ECOG over 3 points, is a very specific and unmet medical record and unmet need. So here starts show the baseline characteristics from the 49 patients. A total of the 49 consecutive patients were enrolled in this study and evaluate the leukemia process. The median age of the patients is 57, and the median time since the diagnosis was 2.6 years. Notably, there are 40 patients at ECOG 3 or 4. A total of 92 of the patients has the DS stage 3. And 76% patients has a reversed 3. This means a lot of patients in a high-risk cytogenetics profile. 33 patients we can see here as double hit. This according to the Mayo Clinic definition criteria. And here we can see we have the 22 patients show the ectodermal disease. The median pro-line previous regimen was for nearly 30% of patients received auto stem cell transplantation, and 60% were refractory to DARA therapy. Here show the overall response rate. The overall response rate can be achieved 66%, with the 43 of the patients having CR or SCR. For the ECOG over 3, we can see the patients still have the very high response rate. They can achieve the 75%. And for the better performance patients, they showed a little bit high overall response rate. When we made the subsequently, we performed the univariate analysis. And when we analyzed with the ORR, it was known that the median pro-line was significant associated with ORR, which showed the patients received more than 4 lines has a very high overall response rate. On the contrary, we can see if the patient received less than 4 lines, they show the very high overall response rate. And after follow-up of 3 years, and the survival analysis was performed here, the median PFS was 10 months, and the median OS was 29 months. It means even for these heavily treated patients, they still have very long overall survival. When we made the subgroup analysis based on ECOG status, patients that have the bad performance showed the supra to patients with a bad performance, not only in PFS, but it also showed in OS, which also suggests to us the CAR-T therapy may be need to put forward in the early stage. And similarly, when we make the analysis for the PFS and the OS-based treatment lines, we can see here, the patients, if received less than 4 lines, they have a better PFS and a better OS. This result also shows the patients need to receive the CAR-T therapy as early as possible. The median treatment line was also associated with MRD and CAR-T expression. Patients with less than 4 lines of therapy showed a better MRD status and the high the CAR-T expression, and several patients still could not detect the CAR-T persistent even after 2 years. All patients have we can see here at 35% CRS, which was a grade 1 and grade 2 in 28% patients, and only 3 patients suffered a very slight CRS grade over 3. There are no patients of CRS of grade 4 or higher. CRS occurred earlier with a median time to onset of the 3 days, and we can see here 3 days. And a median duration of all the CRS, it can present the 8 days. And here, just how to manage to the CR. Some patients received dexamethasone, and also some patients received toximab. When we compared with other studies, patients with better performance, when we compared with other studies, we can see here, this all study we are so familiar with. But our study just saw the very distinguished point is if the patients with better performance still had the response, and even the performance score over 3, they still have the 43 patients that has a very good response rate. And all the PFS together, we can see the median PFS is 10. Especially for the CRS, in our study is not so high, especially for the grade 3 CRS, only 60% of patients suffer this the high side effect. Okay, let's make a short summary. For the CAR-T therapy, nearly 3 years after the first report described CAR-T, which is very efficiently redirected the effector machine to tumor cells. We know CAR-T therapy, especially BCMA, has approved in the USA, but I'm sure the BCMA-targeted CAR-T will be increasingly used in patients, especially with heavily pretreated patients. We know we have so many clinical studies, but from our study, we made the combination used for the patients with very bad performance. But our study showed a very high activity and manageable toxicity of the CAR-T cell in patients with heavily pretreated myeloma patients. So I think our study is very significant because in the next step, you need to enlarge the used CAR-T cell in the real world, especially for the ECOG score as a high patients. And we know we have a lot of increasing number of the study. They just evaluate CAR-T therapy if can use the early stage, such as the first line for the newly diagnosis. But I'm sure all this for the newly diagnosis patients, we will see maybe the patients benefit from this therapy, have the long-term PFS and maybe the long-term MRD negativities. Even though we still have a lot of questions need to discuss for the CAR-T, because for all the CAR-T treatment, we need to very carefully planning. We know all the procedure need to time to prepare for the CAR-T. So if the patients with very rapidly advancing disease, they still have time to wait the CAR T transfusion. So when we perform the CAR T, we need to calculate the time and all the steps. And also another question is the first CAR may be another very good product can help patients shorten all the procedure. And also another question need to pay attention to persistent immune suppression, because some patients may be even the high infection or something like that from the old procedure. So we should think about how to increase their immunology ability. And also, we know have a lot of different criteria concerns CAR T, but for the standard criteria for managed CAR T, we still need to establish. And also for the long-term consequences, because some patients will relapse from CAR T, and if after CAR T, if needed the maintenance therapy or salvage therapy, this is still the open discussion for the CAR T therapy. Another very important question is for the basic research. We know all the CAR T focus on clinical study, but the basic research, how to overcome the resistance or relapse, is still the parallel development of the basic research. And also for the allogeneic CAR T, UCAR T is also in development step. So even though we still to find the right target, right time for the right myeloma patient. That's all. Thank you very much.
So, thank you, Dr. Du, for giving an excellent talk. In the next speaker, I'll ask Professor Wang to introduce the second speaker.
Yeah, thank you so much, Dr. Du. That was a wonderful talk. In the interest of time, we will reserve the questions and answers to the end of the session. Next up, we have Dr. Perales, who is Chief of the Adult Bone Marrow Transplant Service at the Memorial Sloan Kettering Cancer Center in New York. He's also the Vice President for the American Society for Transplantation and Cell Therapy. So without further ado, Dr. Perales.
Hello, everyone. My name is Miguel Perales from Memorial Sloan Kettering Cancer Center, New York. It's a great honor for me to be a participant in this year's APBMT meeting. Today, I will discuss CAR T-cell therapy in patients with lymphoma and share with you experience from real-world data from our center. These are my disclosures. And as many of you know, several CAR T-cell products have now been approved by the FDA for use in patients in the US. This includes patients with ALL up to the age of 26, and adult patients with DLBCL, where we now have 3 approved products, mantle cell lymphoma, and more recently, patients with multiple myeloma. And I refer you to 2 publications from the ASTCT that were published in 2019 in BBMT and are available online. The first paper was a review, expert opinion in collaboration with authors from EBMT, looking at the use of CAR T cells in patients with ALL. And the second one, led by my colleague Tanya Jain, was a publication on the use of CAR T cells in patients with DLBCL. The outline of my presentation today is to share with you some data from the CIDR, which is the CAR T registry from the CIBMTR, that discuss different grading systems and focus really on publications from our center looking at the real-world experience. To date, more than 4,000 patients have been infused with CAR T cells in the US, and obviously this data is incomplete since it doesn't have full accuracy for 2020 and especially 2021. So I assume that we have now reached over 5,000 infusions in the US. The majority of the patients treated with CAR T cells, or at least FDA-approved commercial CAR T cells in the US, have been patients with large cell lymphoma, as well as patients with ALL. So the most commonly used grading now is the ASTCT grading system published by Lee Santamasa and others in BBMT in 2019. And this includes both grading for CRS or cytokine release syndrome and ICANS or neurotoxicity. The grading system is also available on the ASTCT mobile app, which is downloadable for free on both platforms. We've included in particular CRS and ICANS grading in this mobile app. The grading for CRS is a four-fold grading system, grade 1 to 4, which includes fever, hypotension, and or hypoxia. And this is an example of a patient of John Levine's at Mount Sinai who developed neurotoxicity. This patient is actually a psychologist. And every day we ask the patients as part of their neurological assessment to write down a sentence. You can see as the patient progresses from day 6 to 7 to 8, 9, and 10, that his writing becomes more and more illegible. And this is a typical feature of neurotoxicity. For neurotoxicity, we use the I-score, which is something that can be performed at the bedside by nursing staff. And the I-score is then included in the overall ICANS grading, which again, similar to CRS, goes from grade 1 to 4, and includes the I-score, level of consciousness, seizure activity, motor findings, and elevated intracranial pressure or cerebral edema. This paper was published in BMT in 2020 by Chet and Gauthier. And what they looked at was to summarize the incidence of grade 3 or higher CRS on the left and grade 3 or higher ICANS on the right in various clinical trials. And you can see there's quite a bit of variability across trials, and some of it may be driven in part by the type of CAR T cell used, whether it's a CD28 co-stimulated CAR T or a 4-1BB co-stimulated CAR T. But importantly, these trials also use different grading systems, and that may also impact the results. This is the first analysis looking at the impact of using different grading systems that was actually published by Martino Panisi, who worked with me on this in Blood Advances last year. And what Dr. Panisi did was take a population of 102 patients treated at our center with ALL and DLBCL, including 85 patients who developed CRS, and then use the 5 different grading systems available, actually 6. What we see here is that in green is the PEN grading system, and that there's a significant shift to the right with more grade 3 documented by the PEN grading system than with the other systems. Splitting out now the ALL population on the left and the DLBCL population on the right, you see the same pattern with upgrading of CRS grading using the PEN system. What you also can see is that there is more toxicity in general in terms of CRS in ALL patients compared to DLBCL. When we looked at the axi-cell on the left versus tissue-cell on the right, again, we see more toxicity with axi-cell, more CRS than with tissue-cell, which is something that we have all observed clinically. Of course, the numbers here are quite small. We're comparing a total of 36 patients with axi-cell to 13 patients with tissue-cell, so no statistical analysis was performed. But this gives you at least an overview of what these results look like. Switching now to neurotoxicity, there we have 3 grading systems, CTCAE, the CAR-Tox grading, and the ASTCT grading. And what we see here is a shift with the use of CAR-Tox with upgrading of ICANS using that grading system. So again, critical to use a uniform grading system across clinical practice as well as clinical trials so that we can actually compare results from center to center as well as results in different clinical trials. And now let's focus on the real-world experience. I'd like to start off by discussing results published by Dr. Kitsada Wudikan, who's now back in Bangkok and who spent a year with us here at MSK. He published 2 papers last year, one in Blood Advances looking at toxicities in patients with CAR T cells, and one in Blood Cancer Journal looking more specifically at infectious complications. This slide represents the cumulative incidence of toxicity using CTCAE grading over time. You can see that quite high rates of hematologic toxicity, metabolic, infectious, as well as significant rates of neurologic, cardiovascular, and pulmonary complications. On the right, you can see the distribution among patients of these toxicities. More detailed work looking at the hematologic toxicity in particular was published also last year in Blood Advances by one of our former fellows, Tanya Jain, who's now at Johns Hopkins. And this figure represents the count normalization over time after treatment with CD19 CAR T cells. So how many patients actually reached normal counts? And you can see moving from left to right at 1 month, 2 months, 3 months, 6 months, 9 months, and 12 months, that progressively there is a hematologic recovery in these patients. But even when we look at 9 and 12 months, there are still patients who haven't achieved full hematologic recovery in terms of their hemoglobin, white cells, or platelet count. Going back to the paper from Dr. Wudikan, looking at cumulative incidence of toxicities, and here from left to right, from top to bottom, we can see all toxicities, cardiovascular toxicities, infection and metabolic toxicities. And in all cases, most of the toxicities occur early in the first month post-CAR T cells and then decrease rapidly. Similar pattern is observed with, again, from top left to bottom right, with pulmonary toxicities, neurologic toxicities, hepatic toxicities, and gastrointestinal toxicities. So overall, we see a significant burden of toxicity early on and rapid resolution in the majority of patients of these toxicities. In his second paper, he looked specifically at the cumulative incidence of infections. We can see that the rate of any infection at 1 year was over 60%, and close to 60% for bacterial infections, almost 30% severe bacterial infections, and 44% viral infections. Looking specifically over time at the rate of bacterial on the left and viral infections on the right, and splitting this into mild, moderate, severe, life-threatening, and fatal, we see that most bacterial infections were either moderate or severe, and included one that was life-threatening. And for viral infections, we can see that most of them are actually mild, with a few moderate and severe, but there was a case of a fatal viral infection. Dr. Kitsada Wudikan also did a univariate and multivariate analysis to look at risk factors that may explain infections. And the summary results are highlighted here in this table. For all infections, the use of systemic corticosteroids during CAR T cell treatment was associated with increased risk of infections, both by univariate and multivariate analysis. And for severe bacterial infections, we see that a decreased performance status, as well as the presence of infections before CAR T cell therapy, both associated with increased risk of severe bacterial infection on univariate and multivariate analysis. And the underlying biology for this is also seen in this figure, where we can see levels of IgG, which decrease over time prior to recovery, absolute neutrophil count, absolute lymphocyte count, and CD4 T cell count. And you can see there's a dip in all these counts, which then recover over time. But the persistence of CD4 lymphopenia is significant, and therefore these patients all require prophylaxis for PCP or PJP. I'll refer you to a paper published by Joshua Hill from the Fred Hutchinson Cancer Center and my colleague Susan Seo, who's an infectious disease doctor at MSK. This was a How I Treat paper in Blood, specifically looking at infectious complications in patients treating with CD19 CAR T cells. And what they recommend is the standard prophylaxis with quinolone, acyclovir for HSP and VZV reactivation, a short course of antifungal prophylaxis in patients receiving steroids, and as I mentioned, a prophylaxis against PJP. What about other toxicities? This is a paper published by one of my nephrology colleagues, Dr. Victoria Gutkarts, who looked at the risk of renal toxicity in patients treated with CAR T cells. And in this series, we see here a cumulative incidence of CRS of approximately 80%, a cumulative incidence of neurotoxicity of ICANS of around 40%, and cumulative incidence of any renal insufficiency, acute renal insufficiency of 30%, with grade 1 representing 22% and grade 2 to 3 representing 8%. So in general, the risk of nephrotoxicity in these patients is actually quite low, with only 8% presenting with grade 2 to 3 toxicity. And a recent paper, which is accepted but not yet published, a work by John Goldman in collaboration with Dr. Ronnie Schuwal from our center and myself, is looking at cardiopulmonary adverse events reported to the FDA in patients treated with CAR T cells. And so there are a total of 2,600 patients treated with CAR T cells that were reported, including 1,700 with axi-cel and 900 with tissi-cel. And among those patients, 546 had a specific report of a cardiac or pulmonary complication. On the right, you can see the relationship between the different types of complications, including CRS, cardiogenic shock, respiratory failure, thrombosis, cardiomyopathy, pericardial disease, tachycardia, pleural disorders, and hypertension. Looking at this data in more detail, on the left, we're looking at CAR T products associated with increased reporting of CPAEs. And from top to bottom, we're looking specifically at hypertension, which is obviously very common in the setting of CRS, respiratory failure, pleural disorders, and so forth. And we split this up in blue as tissi-cel and green as axi-cel. And so you can see these types of toxicities have been reported with both current commercially available products where we have the most experience. On the right, we split out axi-cel versus tissi-cel. So complications are seen more prominently with axi-cel towards the right, more commonly with tissi-cel towards the left. And the two that are significant are tachyarrhythmias, which are observed more frequently with axi-cel, where we also see a high rate of CRS, as well as what was somewhat unexpected is VTE or thrombosis, which we also see more with axi-cel. And that's something that we still have to try and understand the biology for. Important to note is that these CPAEs are associated with potentially fatal complications. And on the left is the number of reports to the FDA, and on the right is the case fatality rate. And obviously, cardiogenic shock, which has about 60 cases reported, was associated with a very high fatality rate of 80%. But even VTE, which, as I mentioned, was somewhat unexpected, where there are about 30 to 40 case reports in the FDA registry associated with a mortality rate of about 30%. So what can we do about trying to better prognosticate the efficacy and safety of CAR T cells? This is recently published work in the TCT journal of Dr. Marta Garcia-Recio, who worked with me in New York and is now back in Spain. And what she wanted to do is look at the prognostic value of the AIPI, which is commonly used in patients with lymphoma, as well as in pre-transplant, not just at diagnosis. And you can see very clearly here on the left, progression-free survival, on the right, overall survival, that patients with an AIPI of 0 to 1 have a much better prognosis than patients with a AIPI of 2 or more. And the final paper I'd like to share with you, which was just published in Blood Advances this month, September, by two of my colleagues who worked with me, is to look at the E6 calculator. And this is a formula that incorporates LDH, creatinine, and platelets, which are values that are affected in patients with cerebral microangiopathy. And basically, you multiply the LDH by creatinine and divide by the platelet count. This is based on work by Thomas Luft from Germany that has been published now in a number of papers. And he has shown that the E6 score predicts mortality both pre-transplant as well as the onset of acute GVHD. And what we did is use the E6 formula as well as two modifications. Because the creatinine does not change that much in patients with CAR T cells, as I showed you previously, we removed the creatinine in the so-called simplified E6 formula, which is LDH divided by platelets. And then we also incorporated CRP instead of creatinine, since we know from our work and work of others that CRP itself is a prognostic factor for CAR T toxicity. And so this modified E6 formula multiplies LDH by CRP divided by platelet count. So these are easily accessible tools that almost every center should be able to do. And so in this work that was just published by Martina Panisi, in collaboration with Miriam Sanchez-Camilla, when they were both here at MSK, showed that the E6 calculator was actually predictive of various time points of both CRS at the top and severe ICANS at the bottom. As you can see, we looked at 4 time points: lymphodepletion, day -1, day +1, and day +3. And you can see how the 3 different calculators perform E6, ME6, and SE6 for both types of toxicities. And in most cases, the calculators show significant association with severe CRS or ICANS, and this increases as you get further in, which is not that surprising, that the patients with more toxicity are going to have higher values of these parameters. What is important is that when we focused on the ME6, which had the highest, among the highest values on the ROC curve, we showed that ME6 was able to predict severe CRS at several time points: lymphodepletion, day -1, day +1, and day +3. And obviously this has implications for clinical management, since we can identify patients prior to CAR-T treatment who may be at high risk of complications, and therefore decide to either treat them outpatient or admit them if they're high risk, as well as think about strategies to mitigate CRS, either by prophylactic or early use, preemptive use of tocilizumab or other agents such as corticosteroids. Similarly, for ICANS or neurotoxicity, ME6 is predictive at day 1 and day 3. And what's important here is that we have the ability again to predict a severe neurotoxicity before it actually happens, and again, consider potential mitigation strategies. And finally, the one E6 calculator that performed in terms of efficacy was actually ME6, and we showed that there was an association with a complete remission rate after CAR-T cell therapy with the ME6 score. And this was true at day -1, day +1, day +3, and at time of CRS. And this also could be of importance in terms of potential early interventions to prevent relapse. So we could consider, for example, adjunct therapies such as checkpoint inhibitors or others to try and amplify the CAR-T signal. So to conclude, I think I've shared with you significant amounts of data published from our center. The points I would like to leave you with is that it's critical that we use a uniform grading system across clinical practice and across clinical trials, so that we can do comparison between different populations and different CAR-Ts. The CAR-T cells are associated with significant toxicities, but the good news is that the non-relapse mortality is quite low, and that most patients recover from most of these toxicities. And finally, we have identified a tool that is helpful in predicting CRS, ICANS, and has an impact on clinical management, which is the ME6 tool, which can be easily used at the bedside. Thank you for your attention, and I'm happy to take questions.
Much, Dr. Perales. Really appreciate that. I will again take questions at the end of this session. It gives me great pleasure right now to introduce Dr. Francesca Lim, my colleague in the Singapore General Hospital, where she serves as consultant hematologist. She's also principal lead for education and lead for cellular immunotherapy for adult blood cancers in the SingHealth Duke NUS Blood Cancer Center. Over to you, Francesca.
Good morning, everyone. First, I would like to thank APBMT for inviting me to give a talk on the management of relapsed lymphoma before and after CAR T-cell infusion. I have no conflicts of interest or disclosures to declare. I'd like to start my talk by mentioning that patients with lymphoma who currently meet the FDA-approved indications for CAR T-cell therapy are patients who have failed second-line salvage therapy and are in their third or fourth line before they come to CAR T-cell. And therefore, this group of patients have very poor outcome with a median survival of 6.3 months. At this point of time, we currently do not have a direct comparison of CAR T-cell therapy with other treatments, and in this single-center retrospective observational study of 215 patients, they compared the outcomes in patients treated with CAR T versus other therapies. And patients who received CAR T-cell therapy demonstrated a complete remission rate of 52% compared to others, which was 22%. And there was a median progression-free survival of 5.2 months in the CAR T-cell group versus 2.3 in the alternate therapy, and a median overall survival of 19.3 months in the CAR T-cell group versus 6.5 months in the other therapies. So this is very encouraging, and hopefully we will be seeing more of such data being published over time. Since 2017, where tisagenlecleucel was the first CAR T-cell to gain FDA approval for pediatric and young adults with relapsed refractory acute B-cell lymphoblastic leukemia, as well as adults with large B-cell lymphoma, there have been further developments of FDA-approved CARs for other lymphoma subtypes, as well as in multiple myeloma. And we are very pleased that tisagenlecleucel was approved under Singapore CTGTP regulatory framework in March this year. So the management of relapsed patients with lymphoma before CAR always starts by them being referred to our center, where they have a consultation with the CAR team specialist as well as the lymphoma specialist. And during the consultation, we take a history and examination. We look at the disease characteristics with the histology. We look at the previous treatments that the patient has received and the response duration to these therapies. We, of course, explain to the patient why CAR T-cell therapy may be an option for them, how it works, the logistics behind making the arrangements for the cells to be collected and transferred overseas for manufacturing. We mentioned about the toxicities associated with these CAR T-cell therapies, as well as the costs. And often these patients are then referred to the business office for financial counseling. Now, in the event that they have a histology that is something other than DLBCL, or have had less than 2 previous lines of therapies, have active CNS involvement, or any other administrative issues that may not allow these patients to actually receive CAR T-cell therapy, we do not go ahead with this therapy. At the same time, as we continue to see these patients, if they have rapid disease progression or they develop severe organ dysfunction along the way, or their comorbidities deteriorate even further, or they have persistent active infections, then again, they may not be suitable for CAR T-cell therapy. However, in patients who remain relatively stable with a performance status of about 2, and depending, it could even go up to 3, but maybe after treatment, it goes back down to 2, we may consider them for CAR T-cell therapy. And therefore, these are patients that we discuss at our multidisciplinary meeting. So these are patients who maybe have relapsed in auto stem cell transplantation, but are still chemosensitive or may not be chemosensitive, or they are primary refractory. And then comes the discussion of whether CAR T-cell therapy would really benefit these patients, or whether they would benefit from an allogenic stem cell transplantation. During the MDT, we also look at their organ function to determine fitness. It is worth noting, though, that at our center, we took into account the inclusion criteria that was used to recruit these patients into the CAR clinical trials. But then we saw that the real-world data came about showing that CAR T-cell was safe and as effective in these patients in the real world who would not have actually been eligible in the trial. So, for example, 29% of patients would have been ineligible for the Juliet trial, and 53% would have been ineligible for the Zuma-1 trial. And therefore, the take-home message from this study is that patients who received this therapy in a real-world setting would do just as well as patients who received it in a clinical trial. What is important over time that we have recognized that patient selection is paramount, factors that may influence the optimal outcomes of CAR T-cell therapy, and we group them into certain cohorts. They can be patient-related factors where we look at the performance status, the comorbidities, the organ function. We look at disease-related factors, whether they, how many lines of therapy they have received, the duration, the relapse, if they're refractory to chemotherapy, the tumor burden on the CT scans, whether there is extranodal disease manifestations, and we look at the molecular studies as well as gene expression such as c-MYC. We also look at the PD-L1 density on the tumor cells and so on and so forth. There are also treatment-related factors such as the prior lines of therapy as mentioned, and obviously when they come to CAR T-cell therapy, the consideration as to whether they would benefit or not from bridging therapy, or whether there is need to actually go ahead with bridging therapy. We also look at the type of lymphodepletion chemotherapy. However, at our center, all the patients would receive cyclophosphamide and fludarabine. Other factors, the quantity and quality of leukapheresed T cells, which really at this point of time, of course, there's a lot of talk about T cells being exhausted in terms of patients who have been heavily pre-treated, but at this point in time, there is no firm data to suggest that. What we do know now is that MYC overexpression is associated with a worse outcome, and we can see over here that patients who were MYC negative at baseline had a much longer median duration of response, progression-free survival, and overall survival compared to patients who were c-MYC positive. At the same time, a c-MYC negative status and a normal pre-infusion LDH levels were also associated with an improved progression-free survival. And this was seen at 81% at 6 months and stabilized at 75% from a year onwards. So the process of leukapheresis, once the patient is deemed eligible for CAR T-cell therapy, we then obviously arrange for the patient to undergo leukapheresis, and this is done at our center. Usually it can be done as an inpatient or outpatient setting of over 1 to 2 days. If the patient does not have good venous access, then that would require insertion of a central venous catheter. We also do some pre-leukapheresis bloods to try and predict as to whether we will be able to collect sufficient cells, and therefore we do an absolute CD3 count, a full blood count where we look at the absolute neutrophil count before collection as well. Once that is done, the mononuclear cells are then cryopreserved and they are shipped to the manufacturing facility overseas, whereby the T cells are then selected out, they are activated, and they undergo manipulation to make your CAR T cells. And these are then cryopreserved and shipped back to our institution to be infused into the patient. So overall, we're looking at a 6-week turnaround time. What is important before leukapheresis are certain proposed washout periods of treatment. And why is this important? Number one, we don't want therapies that could obviously interfere with the collection of adequate numbers of T cells to make CAR Ts. And secondly, the quality of the T cells collected, we don't want these to also be affected by steroids, by T cell lytic agents, which then may render your T cells to be less potent once they are manufactured to make CAR T cells. Bridging therapy, what do we need to consider? Well, bridging therapy commonly refers to therapy that is administered after the apheresis and before CAR T-cell infusion. And this can comprise of steroids, chemotherapy, targeted therapies, or radiation. Currently, what is a favorite bridging therapy is Pola-BR. And although there is, and this usually, as mentioned, this has to be during the bridging period. So we don't like to give bendamustine before the leukapheresis, but once leukapheresis is performed, then bendamustine is fair enough to go ahead and be given. At the same time, we pay attention to the patient characteristics. If they have a borderline ECOG status, maybe a 2 to 3, maybe with the bridging therapy, you can push them back into an ECOG performance status of 2, and that would be ideal. And patients who have a 2 or 1 performance status tend to do better compared to others with more advanced performance status. We also look at the disease characteristics and really what is the intention of your bridging therapy. Most of the time, the intention is to stabilize the disease and to halt progression. It is not to get the patient into a complete remission. In fact, patients who still have disease, they can go ahead and receive CAR T-cell therapy. Although it does make sense to maybe try and reduce the tumor burden and therefore allow greater efficacy of your CAR, as well as to reduce the toxicities associated with the CAR T-cell therapy. And at the same time, there are recommendations of washout periods for the chemotherapy before the infusion of CAR T-cell therapy. Again, number one, you don't want to give the patient more toxic effects in combination with your chemo and your CAR T-cell. At the same time, you also don't know whether your chemotherapy that you administer before your CAR T-cell will interfere with the function and the potency of your CAR T-cells. So hence the recommendations. For us at our center, we usually admit the patient and the CAR T is infused in the inpatient setting, although there is publication now to show that CAR T-cell therapy can be administered in outpatient setting. And this is really in the context of selecting patients upfront to actually administer the therapy in an outpatient setting. Over here, once they are admitted in an isolated ward, they are then seen by our intensive care unit colleagues, our ID colleagues, as well as the rounding transplant team, really so that everybody has a feel of the baseline status of the patient, both in terms of their baseline activity, their function, and their cognition, which is very important because if the patient was to develop toxicities with the CAR T, we at least have a baseline to go by. After which, once the CAR goes in, we then monitor for acute toxicities. And really, because after lymphodepletion chemotherapy, the patient does become leukopenic and therefore is prone to getting infections. And if they are, we would then cover them with antibiotics. And at the same time, as the CAR goes in, they will proliferate and then will start the complications of CRS and ICANS. So, as mentioned, thus far, we have spoken about all the pre-CAR T-cell workup, paying a lot of attention to patient selection up front, and obviously the infusion. Now we will talk about the adverse events post-CAR T-cell therapy. So we are aware from the pivotal trials that a grade 3 CRS range from about 2 to 22, and a grade 3 neurotoxicity from about 10 to 28%. However, the grading systems used to ascertain these toxicities were different in these clinical trials, and moving forward, we have now standardized the grading for CRS and ICANS through ASTCT. And this is very important in order for us to actually gather data collectively and to then try and improve the management of these toxicities, as well as reduce the risk of subjecting patients to these toxicities as well. I'm not going to go into great detail as to how these toxicities are managed, because I am aware that these are going to be discussed and presented later in this conference as well. So just to go by, CRS has a typical onset about 2 to 3 days and a duration of about 7 to 8 days, and it can range in severity from low-grade constitutional symptoms to high-grade syndrome associated with life-threatening multi-organ system failure. And really, it's a spectrum with macrophage activation syndrome, but rarely will it result in severe hemophagocytic lymphohistiocytosis. Often it is characterized by high levels of cytokines such as TNF-alpha, interferon gamma, IL-1 beta, IL-2, IL-6, IL-8, and IL-10, and this often correlates with peak T-cell expansion. Whereas ICANS tends to have a median onset of about 5 to 8 days and lasts for about 13 to 14 days. Patients may present with toxic encephalopathy with symptoms of mild headache, confusion, and delirium, occasionally seizures, and more rarely but seriously, cerebral edema. And this can occur in the presence or absence of systemic CRS. And usually the patients who present with severe neurotoxicity also demonstrate some evidence of endothelial activation, and therefore they may present with DIC, capillary leak syndromes, as well as an increase in their blood-brain barrier permeability. We are now aware that T cells can and are seen to traffic into the CNS. So really the principles of toxicity management, according to grade, we would give tocilizumab, and obviously if that doesn't work, we would then consider escalation to corticosteroids. And what is very important that as you treat concurrently the CRS and ICANS, make sure that you always rule out or treat other alternative causes such as just a straightforward bundle sepsis or infection that requires antibiotics, or any other infection like a viral infection as well. So hence one does need to be vigilant of other complications that might occur, and not just blame it on CRS or ICANS for the patient's clinical condition. Once the patient recovers and is ready for discharge, of course, advice is given to both the patient and the caregiver. We ensure that they keep a written record of their medications, their body temperature. We continue to ask them to do handwriting at home, and they keep a daily record of what they take orally. We make sure that if they are to go back with the line, that they are familiar on how to take care of the CVC line. However, many times these patients are actually quite well and they may not actually need any form of blood support, and therefore the CVC line is removed unless, for example, if they have an infection that requires antibiotics usage for prolonged periods, then maybe they may need to keep the line. They are also given emails and telephone numbers that they can call in the event that they develop new symptoms. So managing long-term toxicities, what we see in the patients that we have treated thus far is that yes, many of them do become B-cell aplasic and they develop hypogammaglobulinemia, but many times we would treat them if these levels are low enough with IVIG. Patients do get cytopenias of grade 3, and really if these are unresolved by day 30, there could be an immune mechanism involved, and therefore these need to be monitored over time. And in terms of infections, one needs to be continuously vigilant of these side effects, which was obviously demonstrated in pivotal trials that patients were prone to infections up to 56%. So management of B-cell aplasia, as mentioned, we do similar. We dose IVIG at 0.4 to 0.5 grams per kg, and we administer it intravenously every fortnightly. In terms of the management of cytopenias, we do prophylax our patients with PCP prophylaxis with Bactrim and acyclovir, as well as antifungal with fluconazole. These are the recommendations from APBMT for for infection. We follow most of it. However, for example, over here they say antibacterial prophylaxis is not recommended. Routinely, we tend to start ciprofloxacin for our patients when they are admitted for CAR T-cell therapy, but we tend to tail it off once they are out of neutropenia as well. We do give acyclovir, we give Bactrim, and we do monitor the CD4 counts. As well as, again, APBMT recommendations not to routinely give systemic antifungal prophylaxis, but in our patients we tend to give them fluconazole, but we also take a risk approach, meaning that if the patient has previous fungal infections or they have been heavily pretreated, then we may consider giving something different like posaconazole or itraconazole, depending on our discussion with our infectious disease colleagues. If a patient is very stable and is in remission, then they continue to be seen by us on a 3-monthly basis, and after that for a year, just to monitor for late effects. So usually we do the usual laboratories. We screen for viral infections, and we look at the quantitative immunoglobulins, we look at the T cells, the NK cells, the B cell subsets as well, and we do monitor for the CAR T in the patient's blood. I'd like to just share a case that we did. She's a 59-year-old female with no comorbidities. She was diagnosed as diffuse large B-cell lymphoma with a background of follicular lymphoma 3B and had treatment with 6 cycles of R-CHOP. Unfortunately, she relapsed 3 years later, and she came to National Cancer Center where she underwent more cycles of chemotherapy and did go into remission. However, she relapsed again. They were not able to collect her stem cells, and therefore she did not undergo a autologous stem cell transplantation. Since then to February 2020, she was not able to go into remission despite having more treatment cycles, and her repeat PET-CT in December 2019 showed that she had increased avidity in the disease parts as well as new FDG lymph nodes. Fitness-wise, she remained at an ECOG of 2. So over here, as mentioned, her LDH was about 700, performance status 2. On the histology that we repeated, she had moderate to intense CD19 expression. At the same time, we went through a whole history and deemed her eligible for CAR T-cell therapy. She was admitted for the therapy, received lymphodepletion therapy with cyclophosphamide and fludarabine. During this process, she developed grade 2 CRS and a grade 1 ICANS, which we treated with tocilizumab for the grade 2 because she had persistent fever for more than 3 days. But with regards to the ICANS, we just monitored her. And since then, she is now 18 months post-CAR infusion. You can see her disease, she's in a partial response. She hasn't had any opportunistic infections, thank goodness. She is hypogammaglobulinemic, and we are replacing that intermittently. In terms of her white cell count, you can see that she's a bit leukopenic as well as neutropenic. But she's been well, and her LDH is within the normal range as well, and she's got a little borderline thrombocytopenia. So just to end, despite the success of CD19 CAR T-cell therapy, relapses still do occur in a substantial number of patients, and now we are familiar with certain proposed known mechanisms of failure and possibly potential treatment strategies that we could use. So number one, we know that there is CD19 epitope loss, okay, and this is an uncertain mechanism in lymphoma, and therefore one may need to consider other type of CAR T cells or different CD19 epitope to target, as in terms of the genetic sequence. We are familiar that there could be host or tumor factors that could result in failure of the CAR T cell, and therefore using checkpoint inhibitors maybe to modulate the immune system to increase the CAR T cells to proliferate is something to consider. So this is obviously in the setting of patients who relapse but are still CD19 positive, which could then mean that there is a lack of persistence or efficacy of the CAR T cells. And obviously the T cell specific factors, as mentioned before, maybe the T cells that are manufactured to make CAR T cells are already exhausted, and therefore again immunomodulation to try and see whether you can recover any of the T cells or even try and reverse this exhaustion mechanism. So over here, if our patient was to relapse, what we tend to do is that obviously we repeat the biopsy to ensure the cell of origin. We look at certain biomarkers such as the PD-L1. We look at the genetics, whether there's any targetable mutations, and obviously whether if your center offers any form of drug sensitivity, that's something to consider. We look at the patient's we take into account the patient's preference as well as their fitness, and whether at the end of the day they are keen to undergo further therapy or whether they just wish to undergo best supportive care, which is not wrong. And obviously, if they decide to go for therapy, what is important to elicit is whether there are any more circulating CAR T cells. If there is, then obviously we try to use other therapies that will avoid T cell toxicity, or we enroll them in a clinical trial. But if there are no more, then obviously, again, clinical trial comes right to the top, and whether we can use any other agents to treat these patients. If they are fit enough, then obviously comes to discussion as to whether this patient will benefit from an allogenic stem cell transplantation. And with that, I would like to summarize by saying that I hope I managed to impress upon you all that patient selection is key, and that early referral of high-risk patients is important. The real-world data confirms high efficacy as well as low toxicity with in patients with comorbidities not fulfilling the original study criteria. We should avoid T-cell toxic treatment before apheresis, and as demonstrated, the post-CAR T-cell management has become rather standard, and there are certain algorithms in place in the relapse setting to manage these patients if they were to relapse post-CAR T-cell therapy. And with that, I thank you all for your kind attention. I'd like to thank all my colleagues at the Singapore General Hospital, as well as my department, as well as Novartis for their support. Thank you very much.
Thank you so much, Dr. Lim, for a very comprehensive presentation. And now we are at the last speaker. We have Professor Ye from China Medical University. Professor Ye is a director of Division of Hematology and Oncology at China Medical University. His expertise is in the area of hematologic malignancy and bone marrow transplantation. He published more than 80 peer-reviewed articles. Today, he will give a talk on the CAR T-cell and other B-cell hematologic malignancy. Please, Dr. Ye.
I'm Dr. Ye from Taiwan, and thank you very much for inviting me to this symposium. So this is my disclosure. So this is a slide showing the current trend of cell therapy for cancers. So you can see here the number of the CAR T therapy in the preclinical study, in the phase 1, phase 2 study is much higher than the NKT, NK, or all the other cell type. And the number of the cell therapy conducted in hematologic malignancies also much higher than the number studied in solid tumors. And the majority of these cell therapy studies target on B cell and plasma cell malignancies. As you can see here, the majority of the target antigen is CD19, BCMA, CD20, and the CD22. So we can say that the CAR T cell therapy is the dominant cell therapy type in the current time, and the majority of the cell therapy target. So this is the 3 most important CAR T clinical trials for B-cell non-Hodgkin lymphoma, including ZUMA-1, Juliet, and the Transcend. And these 3 clinical trials enroll different patient population, and there are also different inclusion criteria. For example, the ZUMA-1 exclude patients have previous allo stem cell transplant, but the Transcend allow patients previously received the allo stem cell transplant. But in general, all the 3 CAR T trials showing the high efficacy of the cell CAR T therapy for the relapsed refractory non-Hodgkin lymphoma. And for example, the 4-year follow-up of the ZUMA-1 study, we can see the 4-year overall survival is 41%. And you can see here, there is a plateau of the survival curve after the 4 years, suggests many of these patients could be cured after CAR T cell therapy. Because the CAR T have been licensed for the clinical use in United States and in Europe for more than 2 years, right now the CIBMTR and APBMT already have the CAR T registry. So we can use these real-world data to compare the efficacy, the safety in real world compared to the efficacy and the safety in the clinical trial. So because of limited time, I cannot go to the detail for all these studies. But in the short word, the efficacy in the real world is just similar to the efficacy shown in the clinical trials. And for the safety, probably because the more understanding and the more standardization of the measurement of the AE of the CAR T cell therapy. The safety data in the real world seems to be better than the data showing in the clinical trials. So while the efficacy is very good for the CAR T cell therapy, the cost always a very big issue. So this is a study published in last year Blood Journal, the last year ASH meeting. The study enrolled 109 patients of relapsed refractory B-cell lymphoma, failed 2 lines of therapy at the United States. The study compared the total health cost before and after CAR T cell therapy. So you can see it clearly shows that the total health cost decreased almost 50% after CAR T therapy. Suggests if we can have an effective CAR T therapy, we can reduce the total health care cost, and we can save a lot of money. But we can also find the cost of CAR T cell therapy at the United States is very high. In this study, for patients received the inpatient or outpatient CAR T cell therapy, the cost is more higher than $500,000 US dollars in the United States. And I believe this cost is unaffordable to the vast majority of the patients in the Asian countries. In addition to the CAR T, we can also use NK or NKT cells for the treatment of non-Hodgkin lymphoma. For the NK cells, I think it is clear that the use of autologous unmanipulated NK cells is not very effective. If we use the KR mismatch allogeneic NK, the results conflicted, but it is safe and did not induce GvHD. There are some limitations for the NK cell. If we use the allogeneic NK, we need to check the KIR to select a KR mismatch donor, and it will increase the cost. And the patient efficiency is not very high for the NK, and the lifespan is short for NK. So we need to repeat it infusion of the NK cell to see the clinical response. For the CIK, the data, we only have phase 2 data, and the result also very conflicted. It is safe, and if we use the allogeneic CIK, it also did not induce a significant GVHD, but there's still many limitations. The CIK is just similar to the NK. The lifespan is very short, so we need to generate a very big number of the cell to infuse the CIK cell many times, and so that we can see a clinical response. More recently, there's a newly developed strategy using so-called antibody-armed CIK or antibody-armed NK to enhance the specificity to target on the cancer cells, and I will go to more detail later. So this is a phase 2 study using the donor-derived CIK to salvage the post-allo relapse. And in this study, majority of the patients is leukemia, but there are also some patients with lymphoma. The CIK is prepared from the donor, so this is an allogeneic CIK. I think there are two very important information in this study. The first one, if you look at the relapse type, if the patient relapse molecular or cytogenetic relapse, the PFS and the OS is still very good after the allogeneic CIK infusion. On the other hand, if the patient was in a hematologic relapse, if a patient in a high tumor burden, the response to CIK is poor. You can see the PFS and the overall survival is very poor after the CIK treatment. So this, I think, for CIK, it would be better to give the CIK to patients with low tumor burden. And the second important information is use the allogeneic CIK. There is no severe GVHD in this study. So with this concept, we also generate our CIK program in my hospital. We use CIK to salvage patients with low tumor burden or patients with minimal residual disease of leukemia, lymphoma. So this is an example. A 62-year-old female, AML, relapsed 2 years after the haploid stem cell transplant and get second CR after venetoclax and azacitidine, but the MRD remained positive. So I gave the patient CIK cell. When I gave the harvest cell PBMC for the CIK, the PBMC harvest from the patient herself, but when I harvest the PBMC, the patient was in the second CR, so the bone marrow is donor origin. You can see here the carrier type is 46XY. So this is a typical so-called pseudo allo CIK. I give the patient a total of 6 doses of CIK, and the MRD turned to negative after the third dose of CIK, and still remain negative after 6 doses of CIK. And at the same time, we can find the CD8, CD4, the T gamma delta cell number increase after the CIK cell therapy. And importantly, we did not see an infusion-related reaction, and we also do not see a GVHD after the infusion of the pseudo-allo CIK. The antibody-armed CIK and NK cell can improve the specificity of the cell to target on the cancer cells. So this is a novel strategy. First, using the linker to attach a single-strand DNA, and then the compound attached to the NK or CIK cells. In the same time, use the linker to attach a complementary single-strand DNA and attach this compound to a monoclonal antibody to target on a very specific tumor antigen. And put these two together, then the cell will carry a specific monoclonal antibody to target on the cancer cells. If the monoclonal antibody is trastuzumab, then the cell, the CIK or NK, will be targeted on the HER2-positive cancer cells. And if the antibody is the rituximab or obinutuzumab, then the CIK or NK can be targeted on the CD20-positive lymphoma cells. So in the in vitro study, we can see that using the antibody-armed CIK, the efficacy, the cytotoxicity is much, much higher than the conventional CIK. And using this antibody-armed NK or CIK, the cytotoxicity also much higher than conventional NK or CIK. So this is a very novel strategy to enhance the efficacy of CIK and NK. While we are very excited for the rapid progression of cell therapy in recent years, there are also a lot of challenge for the CAR T cells. The big issue is the timing. Should we go earlier for the CAR T cell therapy? So this is a very big debate. Should we give the patient CAR T before or after the auto stem cell failure? So right now we do not have the answer, but there are recently published phase 3 Belinda study comparing Kymriah and auto stem cell transplant for primary refractory B-cell lymphoma. The primary endpoint is event-free survival. The study unfortunately failed to meet the primary endpoint. So at this moment, the use of CAR T did not better than auto stem cell transplantation for primary refractory B-cell lymphoma. If we have the CAR T, should we still do the allo stem cell transplantation for relapsed refractory B-cell lymphoma? We do not know. And the cost and accessibility always a very important issue for the CAR T cell therapy. For the NK and the CIK, I think the most important issue is the patient selection. Based on the current available data, it would be probably better to select patients with low tumor burden or patients with only MRD positivity status to see a better response. And so maybe the use of CIK or NK would be better to use, more reasonable to use as an adjuvant or consolidation to prevent relapse. So there's ongoing study in the United States combine NK cell therapy with standard chemotherapy and auto stem cell transplantation to see if we combine the immunocell therapy, can we improve the transplant outcome? And the role of antibody-armed NK and or CIK based on the in vitro data and the animal data, the efficacy, the cytotoxicity is much, much higher than the conventional NK or CIK. But of course, we need a clinical trial to test the hypothesis. So I stop here, and I'm very happy to take the question. Thank you.
Thank you so much, Professor Ye, for a very interesting and enlightening talk. And now we come to the Q&A session. We don't have any questions from the audience yet, so I think I will start first. I will ask Dr. Du about the CAR T cell in multiple myeloma. So I see that your very interesting data suggesting that patients who receive less than 4 lines of treatment seems to do better after CAR T cell therapy. And as we know that there might be some concern about T cell fitness in patients who are heavily treated. So for multiple myeloma patients, normally how do you recommend when the doctor should refer the patient to see you to consider CAR T cell?
Thank you very much for a very nice question. You mean what we should decide which patients to treat the CAR T? Is that means?
Yeah, I mean, should we treat the patient earlier? Should we refer the patient to you earlier to consider CAR T cell therapy?
Yeah, we really hope, like Dr. Ye has mentioned, the CAR T would be the early, the better. But now in China, it's just in clinical study phase. It means normally for the relapsed patients, they will receive or screen if they candidate for the CAR T trials. But in the real world, we haven't to give this treatment for all the patients. But we already started for the first line or maybe for the after first relapse, put the CAR T before, not so late, like after 4 lines to treat. So I'm sure not only in myeloma, also in lymphoma, the early should be better. But I still have a question because I know you're all the expert on this field. If the patients receive the CAR T at the newly diagnosed stage, maybe the first line. After induction therapy, the patients will be achieved CR. That means for the CR patients, the CAR-T still will be work because it might be no tumor cell, might be no CRS reaction. So what do you think for the newly diagnosed patients after induction therapy to receive the CAR-T?
Anyone would like to share the opinion? I'll start first. I mean, I don't have much experience in multiple myeloma, but I think we have some data in patients with lymphoma who receive T-cell like Lucel when they have no detectable disease. And it seems like, it's difficult to compare, different cohort of patients, but there are some signals suggesting that the overall response rate seems to be better, and I think like a severe immune-mediated adverse event seems to be lower. I and Dr. Perez have another abstract looking at a 15 patients cohort without evidence of disease at the time of CAR T-cell infusion, which we will present at ASH, and we saw the same signal that the overall response rate and progression-free survival seems to be better, and then with lower CRS and IgANs. I don't know, Dr. Lim and Dr. Ye and Dr. Wang, do you have any comments?
Yeah. So if I might just give my own thoughts and comments. Sometimes there may have been a concern that if there was absence of antigen, the T cells would fail to expand.
Right.
But for many of the receptors that the CAR T cells target, there is already innate antigen present in the human body, because B cells as a whole in the human body already have CD19. So when the CAR T cells are infused, as long as it encounters normal B cells, it will already expand. So we don't really have to be so concerned about the absence of tumor in order to exhibit some degree of clonal expansion. Similar things also apply to some of the myeloma receptors, whether it's CD38 or otherwise, because there's already innate CD38 present in the human body to allow for clonal expansion. The requirement for the clinical trials to have some presence of disease in order to recruit a patient onto the clinical trial is because in any trial, you need to have measurable disease to assess a response, right? So CR is one of the criteria. So if you don't have disease, you can't define CR in a clinical trial. But outside of a clinical trial, I don't see that as a prohibitive barrier. Also, if we actually intentionally allow for disease to grow and for even bulky disease, then side effects tend to be a lot more in that patient population.
Agree.
Okay, great. Thank you.
For different B-cell lymphoma, it's a very heterogeneous population, the disease. So I don't think not everyone need a CAR-T as a frontline therapy. But if for a patient with, for example, double hit and some poor growth factor, maybe this patient could be a good candidate for early CAR-T therapy. But I think in the future, there are many effective drugs for the B-cell lymphoma, including Pola used in the early stage in combined with the R-CHOP, including probably using the bispecific antibody. All these would be very effective to eradicate the cancer cells. So I think in the future we have more effective drug to treat the lymphoma. So I don't know. Maybe we really need a clinical trial to see what's the best treatment for the newly diagnosed lymphoma. This is my opinion.
So, Dr. Du, just for me to comment on your question about patients being in a complete remission or basically having very minimal disease and then going to CAR T cell therapy. From our personal experience at Singapore General Hospital, although it's not a large cohort that we've managed thus far, but the patients from that we had treated who actually had even no disease detected on PET scan, which is what Dr. Huang mentioned, these patients of ours actually did very, very well. As opposed to patients who came into CAR T-cell therapy who had very bulky disease or had disease progression while they were being prepared for the CAR T-cell infusion, these patients actually did not do as well. We had one who had very little disease burden and who had very localized disease. And we gave her a bridging radiotherapy. But unfortunately, the 1 month PET CT for her was actually clear, but 3 months down the road, she actually did relapse. So, it is really, at this point in time, I think there's no clear answers. And to link everything together, like what Kit Sider said, Tsitsi still did recruit patients that were, who didn't have any detectable disease in the PET CT, and they actually did very, very well, those cohort of patients. And likewise, I think from all the talks that have been presented, when the tumor burden is so heavy before the CAR goes in, you can see that sometimes the efficacy is not so good. And really that whole concept of the bridging therapy and why that is actually quite important. But maybe myeloma may be slightly different from DLBCL just because of you can maybe select your patients, right? As what Dr. Ye mentioned, the double hits or the double expressions tend to have very high LDH and very accelerated disease, and therefore sometimes it's very difficult to optimize their disease before going to CAR T-cell therapy.
That's great, thank you. But do you can still notice the patients even has a very low tumor burden, still has a high level CAR T expression?
So at our center, we don't really, we have been checking with flow cytometry and they do seem to have quite a high peak expression. Yes, you are right. So that tends to correlate to the response of the disease. Another point to bring out, as mentioned, although some of our patients did not have much tumor burden, they still develop cytokine release syndrome and they still develop neurotoxicity. So hence, I don't think it's also a very clear indicator. And therefore, I think what our speaker from MSK presented, about all these calculations that we can use moving forward to predict CRS and ICANS, I think that's really, really something that we should all work together maybe to use in our institutions moving forward. It would be something very exciting for us to gather data across the Asia-Pac region.
Right. There are some comments that have come in, comments and questions. So I'll just read the comments first. And just to say, I agree with them. Okay, Dr. Alok says CAR T cells, when they're used in patients without measurable disease, you only have relapse and survival as markers, therefore needing longer follow-up. So we agree with that. And measuring MRD is important in many of these. So two of the questions, one of which is a little bit easier, so maybe we'll take that first. For Dr. Ye, the recommended dose for LOCIK infusion.
The use of LOCIK first, this only the phase 2 data published right now, but I think the CIK is not currently the CIK is not very specific to target the cancer cell. So in general, the CIK cell therapy is not very effective to treat the cancer. But in this phase 2 study, we can see if the patient in cytogenetic or molecular relapse, then the response to the allogeneic CIK seems very good because after 3 years, there's still more than 70% overall survival. But if the patient was in a hematologic relapse, then the allo-CIK is not very effective. So if the patient have a very high tumor burden, I believe the CAR T would be much, much better than CIK or NK. But if a patient in relative low tumor burden or in MRD status, probably the use of CIK would have some benefit. But I think the cost would be an issue. For example, in Taiwan, the cost of a CIK cell therapy roughly the 10% to that of the CAR T. So I think maybe some patient, I would say for patient with big tumor burden, I never recommend the CIK or NK for this patient. But for patient with minimal residual disease, this is an option. This is my opinion.
Right, thanks so much. And one more question on it was, if a patient has early loss of CAR T cells on the peripheral blood by a month after infusion, what would you do? Reinfusion, observation, or any immunomodulatory medicines? A bit of a hard question. Anyone, including Dr. Quezada?
Personally, because I have experience with commercial CAR T cell when I took sabbatical, I think normally we don't really check CAR T cell routinely, but as we have data right now, I don't think there is any recommendation to reinfuse. Even the patient do not have any measurable CAR T cell in their peripheral blood. I think even, we reinfuse a patient, there are some data from Fred Hush that look at patients who have reinfused CAR T cell therapy. And the concern is that there might be some, antibody against CAR T cell because of the murine SCFV fragment of the CAR T cell, which would relate to lower expansion and also lower efficacy for the CAR T cell infusion. So personally, I wouldn't do anything unless the patient have a sign of relapse disease by the time of no CAR T cell detectable.
Yeah, so just to clarify, Dr. Wang, did you say that the patient has no disease, but basically there's no more circulating CAR T cells? Is that the question?
The question is just pertaining to, no circulating. It didn't specify about any level of disease. But of course, obviously if you have disease, you would do something, right?
Yeah. So I think it's what, Dr. Quezada mentioned, we wouldn't do anything as well unless there is obviously disease, because at this point in time, I don't think there is any standardized way of actually monitoring the CARs. Right. There are certain recommendations that you can use flow cytometry or PCR molecular ways, but nothing is at this point in time gold standard. And therefore, I think unless your center, and you have another center that you can compare your, how well you can detect the CARs, then that may be something. But otherwise, we would obviously go clinically moving forward. And you have other clinical markers which are probably, better to go by, as mentioned in the talks today, like your LDH, your CRP, all that is actually relevant in that kind of context when you want to monitor your patient.
I guess the only thing I would do is I would call the lab to say what happened. So, yeah.
All right, so I think we are running out of time. So I would like to thank Dr. Wang and Dr. Du, Dr. Ye, and Dr. Lim for being here and have a very good session and discussion today.
Thank you so much.
Thank you so much.
Thank you. Excellent.
Bye.
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 Bye-bye. Bye-bye. Bye-bye.
Okay, good morning, everyone. Welcome back to APBMT 2021 virtual meeting. The next topic is on the meeting room B. As everyone all know that the transplantation and the cellular therapy is a multidisciplinary approach, involve many healthcare personnel. Today, it is very interesting and honor of us to have the next topic, which is interesting. Our topic is the highlight of pharmacy aspect in transplantation and cellular therapy. My name is Adisak Tantivaravit. I'm the chair of this topic. Today is our great honor to have all the three speakers. That is Trai Thanpanit from Thailand, Ho Ying Chi from Singapore, and Dr. Boyu from China. So let's begin on the first topic. The first topic is the common drug interaction and management in BMT patients. This will be presented by Dr. Trai Thanpanit. Dr. Trai Thanpanit is currently instructor at Department of Pharmacy Practice, Faculty of Pharmaceutical Science, Chulalongkorn University. Dr. Trai completed an oncology clinical pharmacy resident at College of Pharmacotherapy of Thailand. After that, he underwent board certified oncology pharmacist from American Pharmacists Association. Right now, he is teaching PharmD candidate and pharmacy resident. He also has been doing hematology oncology care at hematology and bone marrow transplantation ward more than 7 years. He also served as an academic committee of the Asia Pacific Oncology Pharmacy Association. It's our honor to have him here with us today. Dr. Trai, please.
Hello everyone. I have to thank you to the APBMT 2021 committee for inviting me to be a speaker here in this conference. I'm very honored to be here. My name is Trai Thanpanit. I am from Department of the Pharmacy Practice, Faculty of Pharmaceutical Science, Chulalongkorn University, Thailand. In my session, I will talk about common drug interaction and management in bone marrow transplantation patients. Today, I will review a bit about what is drug interactions, and I will touch a little bit about the prevalence of drug interaction, especially in the BMT unit. Then I will select the drug interaction list from the most prevalence in the clinical studies. I will show you about the mechanism and the management of each drug interaction. Drug interaction is the possibilities that the one thing, for example, like a drug, foods, medical devices, diseases, for example, may alter the intensities of the pharmaceutical effect of another drug. That give concurrently. This result is either to increase or decrease the activity of the affected drug, which may lead to increase the toxicity or reduce the activities of the affected drugs. Drug interactions can be categorized into groups. First is the pharmacokinetics interaction, which is absorption, distribution, metabolism, and elimination, or pharmacodynamics, which is the pharmaceutical effects interaction, such as the agonist and antagonist in each combination. Study that related about the prevalence of the drug interactions involved in BMT unit was limited information. Prevalence of the drug interaction in the BMT units was around 33% to 60% that have more than one potential drug interaction. The number of the drug interaction is around 1 to 11 times. We found pharmacokinetics interaction more than pharmacodynamic interaction. Common drug interactions are cyclosporine, phenytoin, fluconazole, and proton pump inhibitor. So if we divide BMT process into 3 states: conditioning, engraftment, and immune recovery, we used chemotherapy, anti-emesis, and anti-epileptic in the conditioning regimen of conditioning states. About the engraftment states, we used many medication to prevent the infection, such as azole, antiviral, or sulfamethoxazole trimethoprim, for example. Especially for the allogeneic stem cell transplant, we must use the immunosuppressive to prevent the graft versus host disease. So if we look at the metabolism profile of the common medication list on the left-hand side, we show that the list of the medication that are not metabolized but led by the cytochrome P450 enzymes. For example, busulfan is metabolized by the glutathione S transferase. Melphalan and cytarabine are metabolized by the specific enzymes intracellular, for example. You will see in the list, this list are the chemotherapy that's widely used in the conditioning regimen. On the right-hand side of this table, for example, erythropoietin, cyclophosphamide, genothiothebar, immunosuppressive agent, AK receptor antagonists are metabolized by the CYP3A4. Phenytoin has the CYP3A4 inducer effect. At last, azoles are metabolized by the CYP3A4 and has CYP3A4 inducer effect. So you will see that it will have a lot of change to happen drug interaction. I will start with the busulfan and fludarabine interaction. This combination is widely used in conditioning regimen to do BMT for AML and MDS patients. The mechanism was not fully known. Data of effect of this interaction are not unclear. Some study found fludarabine was not effective busulfan PK, but some study found fludarabine can decrease the busulfan clearance and can increase the AUC busulfan concentration at the steady state and the maximum concentrations of the busulfan. In this slide, I will show the data that the fludarabine affect to the busulfan PK. The first study evaluated the influence of the fludarabine on the oral busulfan PK to the BMT patients. The patients that concurrently treated with the fludarabine showed the reduced busulfan clearance. 110.5 versus 157.4 and higher AUC 0 to 6 hours than the patient subsequently treated with the cyclophosphamide 7.9 versus 5.7. For the second study is the retrospective analysis in the adults who received the IV busulfan OD or daily in the one objective of this study is evaluated the factors associated with the busulfan clearance that show in the table. Clearance decreased significantly in the patients receiving fludarabine concurrent with the busulfan. In this slide, I will show you the data that fludarabine was not effective to the busulfan PK. In this study, they want to test the linearities and stabilities of the busulfan IV in between the busulfan combination with the cyclophosphamide. They represent in MAX protocol, and the fludarabine with the busulfan they represent in REC protocol. You will see the AUC and the currents of busulfan burnout difference between two groups is around 1,000 and 0.74 respectively. In conclusions about this interaction between busulfan and fludarabine, the effect of this interaction still controversy. We should, do the therapeutic drug monitoring or TDM of the busulfan to adjust the busulfan dose appropriately for, sequences of fludarabine and busulfan administration. Most of the clinical trial they give the busulfan before the fludarabine. So, in my opinion, we should give the fludarabine before busulfan based on the clinical trials. Next, I will talk about the interactions between the busulfan and cyclophosphamide. Mechanism of this interaction is busulfan is mainly metabolized by glutathione as transferase of glutathiones, and the one pathway of cyclophosphamide detoxification is glutathiones conjugation. So if we give the busulfan and cyclophosphamide at the same time, busulfan can decrease the glutathiones, right? And then for that reason, toxic metabolite of the cyclophosphamide can be accumulated. At last, can increase the adverse drug interactions of the cyclophosphamide, such as VOD or liver toxicity. So we should give the cyclophosphamide after busulfan, more than 24 hours interval. Well, next I will talk about the busulfan versus the phenytoin. If you look about the metabolism profile of the busulfan, it's widely known that metabolized by the GTS and glutathiones, but on the CYP3A4 still controversy. In the phenytoin, metabolism profile is widely used in the seizure prophylaxis from the busulfan is substrated of the CYP2C19, MRP4, for example, has the CYP2C9 inhibition effect, and also has the CYP2B6, CYP3A4, CYP2C9, CYP2C19, and GTS inhibition effect also. So if we use the busulfan combination with the phenytoin, found effect that phenytoin can increase or can induce the GST serum level of the busulfan can be decreased. At last, the incidence of the disease relapse can be increased. However, based on the many clinical studies, confirm that the phenytoin does not, affect to the busulfan serum level, including does not change many clinical outcomes. For example, survival, disease survival, transplant-related mortality, disease relapsed, for example. The other thing that's about the disadvantage that I want to show you about the phenytoin are the dosing administrations is quite complex. If you compare with the clonazepam and levetiracetam, the both of medication that have the comparable results when compared with the phenytoin for busulfan seizure prophylaxis in some studies. The second thing is the metabolism profile that can be lead to PK interaction. That clonazepam and levetiracetam are less chance to happen. The common side effects of phenytoin is, in my experience, is the sedations that can be found less in the levetiracetam. Okay, come to the last interaction is the immunosuppressive agent with the azoles. I will start with the metabolism profile again of both groups. In immunosuppressive group, you will see most of the medication are substituted by the CYP3A4 except the mycophenolate mofetil. In the azole group, is widely known that can be inhibited CYP3A4, but different on the severities of the inhibition. So we can guarantee that they have interaction for each other for sure. These dose adjustment recommendations based on the alterations of the AUC of the immunosuppressive from the azole. For example, when you combination with the tacrolimus with the oral fluconazole, we should reduce the tacrolimus dose by 50% of the full dose, for example. Okay, in enterocyte can be found the CYP3A4 and P-glycoprotein. When we change immunosuppressive agent from IV to oral route, that can be enhanced to higher effects of these interactions. I will explain you more. You can imagine that if you use the IV route, the effect of the CYP3A4 can be found just only in the hepatocytes or in your liver. But if if we change to the oral route, the effect of the CYP3A4 can be found in two ways: enterocyte and hepatocyte. The result is when we change the immunosuppressive route from IV to oral by use the same dose, that can has the supra therapeutic level. Okay, I will show you a study that confirms this effect. This study is a retrospective study that converting cyclosporine from the IV to oral route by the converting ratio is 1:1. They look at the three groups of the patients with no combinations of any azoles, combination with the fluconazole, and combination with the voriconazole. You will see in these slides, in the azole combination group, have the cyclosporine serum level more than no azole combination. It is confirmed that the azole can increase the immunosuppressive availability, can be cause a higher serum level, and can increase the toxicity of the immunosuppressive agent. So we should concern to reduce the IV to oral conversion ratio of the immunosuppressive. Actually, until now, there is just only cyclosporine that has a PK study to evaluate it about the effect of the azole in IV to oral conversion. You will see if no azole combination, conversion ratio is about 1:2 to 1:3, but when the combination with the fluconazole or voriconazole, conversion ratio is reduced to 1:1 to 1:2. For tacrolimus or sirolimus, may not have a study to suggest a conversion ratio. However, it's very important thing when we convert immunosuppressive from IV to oral, we should monitor immunosuppressive serum level closely after converting. Okay, in conclusion, you will see the drug injections that can be found a lot in the BMG patients. Fludarabine versus busulfan, the mechanism is still controversy, but I think the recommended to give the fludarabine before the busulfan also. About the busulfan versus the cyclophosphamide, the mechanism is the busulfan reduce the GST, the toxic metabolite of the cyclophosphamide can be increased. So we should give cyclophosphamide after busulfan more than 24 hours interval. About the busulfan versus phenytoin, the mechanism is the phenytoin is GST inducer that busulfan serum level can be reduced. That can, but that does not change the busulfan PK and clinical outcomes. However, from the complexities of the dose administration, potential drug interaction, and side effects that can be happening more, I may consider to change to the levetiracetam for the busulfan seizure prophylaxis. At last, the immunosuppressive versus ASO, the mechanism is the ASO have the CYP3A4 and P-glycoprotein inhibitor. Then the immunosuppressive serum level can be increased. Importantly, immunosuppressive converting for the IV to oral can be had effects more from the azos. We should reduce the conversion ratio of the immunosuppressive and recommend to do the TGM closely after converting. Okay, that's all in my presentations. I really appreciate it to answer your question. Thank you very much.
Okay, thank you very much, Dr. Dry Tanwanish, for your excellent and comprehensive talk. We will keep the Q&A question at the end of all three speakers. So Dr. Dry, please stay with us. And for the audience, if you have any question or any comment, you can type down in the Q&A box, and it will show after that. I will ask the question for you. So let's move on to the second topic of APBMT 2021 today, of the highlight of pharmacist aspect in transplantation and cellular therapy. It's our honor to have the second speaker here with us today, Dr. Ho Ying-shi. Dr. Ho will come to the talk in managing patients receiving CAR T-cell therapy from pharmacist perspective in Singapore experience. Dr. Ho is a principal clinical pharmacist in hematology and stem cell transplantation at Singapore General Hospital. She had her Doctor of Pharmacy at National University of Singapore. After that, she underwent further special training in hematology oncology at the National Pharmacy Residency Program and achieved her board certification in hematology and oncology. She is now appointed as the Allied Health Education Co-Lead at Sing Health Duke NUS Cell Therapy Center. Her expertise is in clinical stem cell transplantation, cellular therapy, especially in the area of graft versus host disease and the therapeutic drug monitoring of calcineurin inhibitor. Dr. Ho, please.
A hematology and bone marrow transplant pharmacist at the Singapore General Hospital. I also hold appointments at the Sing Health Duke NUS Cell Therapy Center. Before I start, I would like to take this opportunity to thank the APBMT Organizing Committee for the kind invitation to speak at the conference. Today, I'll be sharing our Singapore experience on managing patients receiving chimeric antigen receptor T-cell therapy, also known as CAR T-cell, from a pharmacist's perspective. These are my disclosure and disclaimers. In the next 15 minutes or so, I will focus on the indications and options for antimicrobial prophylaxis. Beyond that, I also share the use of GCSF and IVIG in this patient population. Infections are one of the most common side effects associated with CAR T-cell therapy after CRS and ICANS. This is expected due to the prolonged and protracted neutropenia in this patient population. As we know, the combined effect of prior treatment increased the risk of opportunistic infections in patients receiving CAR T-cell therapy. Prior treatment typically include immunochemotherapy, autologous or allogeneic stem cell transplant, bridging chemotherapy administered after leukapheresis, and lymphodepleting conditioning. It is estimated that 1/3 of patients have prolonged neutropenia for at least 30 days, and up to 20% of patients have neutropenia lasting for more than 90 days. B-cell depletion and hypogammaglobulinemia are additional risk factors for infections. Most infections are seen within the first 30 days, are generally bacterial in nature. And to a lesser extent, respiratory viral infections may happen. Of note, invasive fungal infections are rare and are mostly observed in ALL patients who have undergone prior allogeneic stem cell transplantation. In these illustrations, it gives you a broad overview of the incidence of infections at different phases post-CAR T-cell therapy. Phase 1 is defined as the first 28 days post-CAR T-cell therapy when patients are still neutropenic, with possible concomitant use of anti-inflammatory treatment for managing CAR T-related toxicity. This includes steroids or the use of tocilizumab. Phase 2 is defined as up to 3 months post-CAR T-cell therapy, where patients are typically out of neutropenia, but expected to have impaired cellular and humoral immunity. Phase 3 is considered as late phase, and patients may have B-cell aplasia or hypogammaglobulinemia, which predispose them to opportunistic infections in the longer term. Overall, we can see that infections are a real concern in phase 1, ranging from bacterial, viral to fungal. As we move on to phase 2, the nature of infections shift towards respiratory virus, fungal, and pneumocystis, also known as PJP. In the late phase, patients are still at risk for infections intermittently. Generally, there are no clear recommendations on antimicrobial prophylaxis in CAR T-cell patients, and most studies adopted standard practices extrapolated from the allogeneic hematopoietic stem cell transplantation population. The current practices for antimicrobial prophylaxis at Singapore General Hospital were derived from the APBMT guidelines, international guidelines, and best practices around the world. This is the summary of APBMT recommendation. For antibacterial prophylaxis, it is generally not recommended in CAR T cells trials. However, it can be considered in cases of prolonged neutropenia with a fluoroquinolone. Antiviral and anti-PJP prophylaxis are consistent with the transplant population and are adopted in the trial setting and also recommended by APBMT. Of note, duration of therapy are guided by the CD4 counts of at least 0.2, as per the APBMT guidelines. At SGH, in view of the anticipated prolonged neutropenia, we advocate for antibacterial prophylaxis with fluoroquinolone until patients are out of neutropenia. The drug of choice at SGH is oral ciprofloxacin at 500 mg twice daily. All our CAR T-cell patients also receive prophylaxis for herpes virus, starting from lymphodepleting conditioning until 1 year post-CAR T-cell infusion, and or until CD4 is at least 0.2. The drug of choice at SGH is oral acyclovir 800 mg twice daily. All our CAR T patients also receive prophylaxis for PJP because lymphodepleting conditioning use typically consists of purine analog such as fludarabine. Having that said, prophylaxis should only commence following recovery from neutropenia or at around day 21 if neutropenia persisted at the discretion of the attending physician. Our drug of choice at SGH is oral Bactrim, and we continue at least until 1 year post-CAR T-cell infusion and or CD4 counts of at least 0.2. For patients with contraindication to Bactrim, the alternative would be intravenous pentamidine or oral dapsone. Nebulized pentamidine is no longer preferred in light of infection control during COVID pandemic. The use of antifungal prophylaxis in patients receiving CAR T-cell therapy is not straightforward and dependent on patients' risk factors. It is not routinely recommended by APBMT unless in the setting of prolonged neutropenia or when the patient is on corticosteroids. At-risk patients defined as prior allogenic stem cell transplant, prior invasive aspergillosis, or receiving corticosteroids should receive oral posaconazole. Having that said, a survey was conducted by APBMT, and we can see that practice varied across different centers. Out of the 30 respondents for the survey, 87% reported using antifungal prophylaxis and 13% did not. Most used agent was fluconazole. Other agent used include micafungin or a more active antifungal. Majority discontinued antifungal prophylaxis at neutrophils recovery. About 29% continue beyond 60 days, and 4% indicate a duration based on patient-specific characteristics. We also understand that each antifungals have a different degree of coverage. Of note, fluconazole does not cover for aspergillus, as shown in this activity spectra. At SGH, the primary antifungal prophylaxis adopted is with oral fluconazole. At-risk patients defined as prior allogenic stem cell transplant, prior invasive aspergillosis, or receiving corticosteroids should receive oral posaconazole for additional more coverage. In patients who are already on treatment for pre-existing fungal infection, the choice of antifungal agent for secondary prophylaxis will be made in consultation with an ID physician. Also, taking into account for potential drug-drug interaction between cyclophosphamide active metabolites and azoles, we recommend to start antifungal prophylaxis after completion of lymphodepleting conditioning or on day 0 of CAR T-cell therapy, and to continue until recovery from neutropenia. In these illustrations, it provides a broad overview of the timeline that we can start each antimicrobial prophylaxis and also the expected duration of therapy for each agent. It appears that we should be able to stop antibacterial and antifungal when patient is out of neutropenia. Also, we should be able to start PJP prophylaxis around day 21 for a period of at least 6 months to a year. Antiviral should be continued throughout up to 1 year. Lastly, we may consider stopping antiviral and anti-PJP prophylaxis when patient CD4 is at least 0.2. Moving on, the use of G-CSF in patients receiving CAR T-cell therapy is controversial. As you can see from the APBMT guideline, recommendation is not consistent. Of note, we should avoid GCSF if patient has any ongoing CRS or ICANS because of theoretical concerns regarding macrophage activations. In the survey conducted by APBMT, there were varying practices amongst 28 respondents on the use of GCSF. 46% used GCSF according to product labeling, 29% never administered growth factors, 40% determined the use of growth factors on the patient-specific basis, and 11% administered growth factors to all patients. Therefore, it appears that some administer GCSF as standard of care during periods of neutropenia, while others recommend GCSF only for patients with neutropenic fever. Conventionally, GCSF was postulated to increase the risk of CRS and ICANS. Therefore, based on the product labeling, it is not recommended, especially for the first 3 weeks of CAR T-cell infusion. Having that said, in this study conducted by Gali et al., they reported that administering GCSF prophylactically in patients with relapsed refractory DLBCL and grade 4 neutropenia did not increase the risk of severe CRS or ICANS. The study had a sample size of 70 patients where 40% received routine GCSF prophylaxis versus 60% who did not. Interestingly, it was found that GCSF prophylaxis was able to reduce the duration of hospitalization between the two treatment arms by about 2.5 days, and this was statistically significant with a p-value of less than 0.001. The authors went on to conclude that administering GCSF from day 5 as prophylaxis in neutropenic patients did not increase the risk of experiencing severe CRS nor ICANS. GCSF administration seems not to interfere with CAR-T expansion kinetics and was deemed safe in preserving CAR-T anti-lymphoma activities, with no impact on the quality of responses and outcomes. Therefore, the authors concluded that routine GCSF administration seems to be safely considered in the context of CAR-T treatment for relapsed refractory DLBCL. Given that CAR-T therapy is still a relatively new therapy and that we have varied practices across the board, the consensus at SGH is not for routine GCSF prophylaxis. However, we may consider the use of GCSF after day 5 of CAR-T infusion, provided it is clinically indicated and there is no ongoing CRS or ICANS. Next, we move on to the use of intravenous immunoglobulin in our patient receiving CAR T-cell therapy. We know that monitoring of serum immunoglobulin is crucial because of B-cell aplasia and hypogammaglobulinemia caused by CAR T-cell therapy. Once again, referring to the APBMT guidelines, it is recommended to monitor IgG level, especially in the setting of infections and in children population. Although evidence is lacking in the adult population, we propose monitoring and replacement of IVIG at a dose of 0.25 grams per kg when the serum log-G level falls below 4. In patients who are obese, we will use adjusted body weight in calculation of the weight-based dosing. Beyond 30 days of CAR T-cell therapy, we also recognize that CMV viremia is a concern. However, there is no recommendation concerning the frequency of CMV monitoring after CAR T-cell therapy. Therefore, at SGH, we monitor CMV PCR every 1 to 2 weeks, starting 30 days after CAR T-cell infusion. In conclusion, patients with hematological malignancy receiving CAR T-cell therapy are known to have a very complex pharmacotherapy. Antimicrobial prophylaxis is an important supportive care for these immunocompromised patients. Pharmacists are capable of evaluating the risk of opportunistic infections, anticipating the type of antimicrobial prophylaxis required, and setting a policy with a robust antimicrobial regime. This can therefore promote consistency in patient care and improve patient outcomes in terms of morbidity and mortality associated with opportunistic infections. With that, I have come to the end of my presentations, and these are my references. And finally, before I end, do allow me to take this opportunity to thank my awesome pharmacy team at SGH, and also the team of dedicated doctors, transplant coordinators, and nurses whom we work with very closely. Thank you everyone for your time. Thank you.
So, thank you very much, Dr. Ho, for your nice and comprehensive presentation. We will have the question and answer Q&A session at the end for all three speakers. For the audience, if you have any question you want to comment or ask Dr. Ho, you can type your question or comment in the Q&A box, and after that, we will discuss and answer that question at the end of this session. So, let's move on to our last speaker on the highlight of pharmacy aspect in transplantation and cellular therapy for APBMT 2021. Again, it's our honor to have Dr. Boyu with us. He will talk with us in the topic of pharmacist's role in hematopoietic stem cell transplantation unit. Dr. Boyu graduated with a Master of Science in Pharmacology from the Shanghai Institute of Materia Medica at the China Academy of Science. After that, he went to his clinical trial and research in South Texas Research Therapeutic in San Antonio, Texas, USA. He also achieved a visiting scholar at the Ohio State University Comprehensive Cancer Center at Ohio, USA. Right now, Dr. Boyu is currently a deputy chief pharmacist at Fudan University Shanghai Cancer Center, as well as he also served as the Shanghai Proton and Heavy Ion Center, Shanghai, China. It's our honor to have him here with us today. Dr. Boyu, please.
Hello everyone, this is Bo from Shanghai, China. I am so honored to join this session and to share a little bit experience in pharmacist's role in HSCT unit. Hope after this session we can share more about what we are doing and what we can do in the near future for these patients. So for my talks, I'm going to talk a little about the transition of care in two aspects: inpatients and from inpatient to outpatients. And also in this COVID-19 era, shall we do something different to help them? And also for the medicine adherence is always a very big problem. What we should do to help more, to support more with outpatients. And following this part, still we need to face in education. This education not only to pharmacists and also to patients and also to any other caregivers. So for the last not least one is the research part. For the research part, what pharmacists could do in this kind of service and what new role and pharmacists could play and what new evidences pharmacists could to create for these services. So the first to talk about is the transitional care. For this part, we know that the critical points, including I think for two aspects. The first one is when the patient is still in the same hospital. That means that the patient is moving in or out from the ICU facilities or the transplant module facilities. And as the patient is discharged as an outpatient, so they go to follow up to get other services from community hospitals or clinics. So for this part, I think the critical point is how to reduce the potential errors. Because when the patient is getting discharged, so they will receive inadequate medication reconciliation and absence of patient involvement in medication management. So what we could do in our hospital, we really tried a lot. The first is before discharge, and actually in every day, our pharmacist, as we show in the red arrow, we will join the team rounding, and after the rounding, we're going to go to meet each patient, let them know what they should do, what they should know, and we're going to continue our service to the community hospital clinics, as seen in the pictures from the right above. We can see that our pharmacist is going to the community clinicals to give advices or meet our patients there. And also, when the patients cannot go access to hospitals, they can go access to the community hospitals. You see that in the lower right picture, that we still go rounding there in the community hospitals to continue to give efforts, give the help to them. So this, when we're talking about transitional care, is kind of thing that we can see that beyond our everyday practice, but this is what we should do for this specific patient's population. Then we are still in the era of COVID-19. This already lasts for 2 years, still a big problem here in China. So first, let's take a look at the lower table. This is the number from my hospital. And for the year before COVID-19, in the 2018-2019, you can see that for the allogenic patients, HSCT, we do a lot. And it seems that it's kind of funny that after the COVID-19, our allogenic or autogenic patients is not decreasing, it's still in a stable. But we noticed that for this kind of patient, their hospital stays is around almost 3 to 4 weeks for autogenic patients, but for the allogenic patient is 5 to 6 weeks. We know that is far from enough. So this shows that more attention or more care is given to this kind of patients in the community clinics. So this also indicates that our service should be extended to more extensive spread out services. And for more information about the medication fees that we charged, this part of our Tony Hospital data that we noticed that for the outside world that we are noticing that a really big reduction in patient admission rates. We can see that from the left above pictures that the gray bar is far more less than the blue bar. So this is kind of trend that, and also we notice that is statistics that we can see from the right above table that when the patient transit from inpatient to outpatient, we can really notice that a significant reduction of total expenses that we can notice from this report, that up to around 50% reduction of total expense. So put them all together, that COVID-19 kind of accelerated the transition of care we need to give to this kind of patients. And now we come to the adherence part. Medication adherence we know that is the most important factor defining treatment efficacy. This adherence is particularly challenging to enforce in the setting of HSCT as post-transplant medication for preventing a variety of transplant-associated complications, including a lot of drugs used such as immunosuppressants, anti-infective drugs, and others. Adherence to medications was reported to fall below the recommended 80% to 95%. I know this is hard to reach, because per this report that 1/2 of allogeneic HSCT patients reported non-adherence. So this is a really big problem that we know our target, but the reality is far from that. And we also notice that the younger age experiencing distress and a higher number of needed medications are associated with the medication non-adherences. But we all know that when the patients experience an HSCT, they are taking a lot of medication, a lot of pills. So that's why we see that very important that we need to continuously do our medication reconciliation. And since this patient going to act as outpatient, so our service need to go beyond our hospital entrance. We need to go to communities. But how can we do that? Let's see about the left to lower table that although from the GVHD numbers that between the intervention group and the control group, that we cannot see any significant difference before with pharmacy intervention or without pharmacy intervention. But however, we do notice that as we show in the left to upper table, that the mean serum concentration of immunosuppressants are really higher if we offer pharmacy intervention. So that shows that we can help to do this medication adherence that by pharmacy intervention. But what to do? Here's something that we are doing, and we need to do this. Education for this HSCT and cellular therapy should be carried out not only to patients, but we know that, but also to caregivers. This is to and the contents should include but not limited to instructions to take the medication correctly at the right dose and the right time. We all know that, and pharmacists also educate others on potential drug-food, drug-herb interactions. Besides helping to shape new programs for HSCT-related pharmacy services, we should also do the following things. The first of all is, before discharge, we need to tell the patient that, help them to do medication reconciliation with a completed list of medication. So they will understand which one to take and why to take and how to take. And the discharge prescription summarized on a personalized drug schedule should be offered to the patient and expanded. And the importance of optimal adherence and the potential problems related to self-medication should be expanded to the patient as detailed as possible. And we try to do something more that, as the report says, that consultation after discharge should be given, for example, 2 weeks and 4 weeks after discharge. And actually, we are trying now to establish a follow-up system that can follow up as our set schedule. For example, right now, the longest follow-up duration for my patient is up to 3 years. So during this 3 years, we can do this consultation again and again to help them, to accompany them to experience all these steps. So And the last not least is to suggest that if we possible for hospitals, they have this facility, they can doing TDM to test the serum levels of all kinds of inhibitors. That can also do a lot of help. Okay, now we go to the research role that we are doing right now in our hospital and probably in many other hospitals around the world. This shows what they are doing. Since I'm also in charge of phase 1 clinics, so this is my pharmacist as shown in red arrowhead. He is not they, although this here showed only he, but also there are several of these pharmacists that I'm hiring that they not only attending the protocol discussion part with the PIs, with the CIOs, with this kind of supportive people. He also in charge of the patient interview before he or she got recruited. By doing this, we also established several multi-centers kind of trials to collect all this kind of data. Why we doing this is not only to support, but also that we're trying to establish or to find some positive signals that can tell us what is going on with the patients and what probably will happen. So we can do this in advance. Another thing before my summary is access problems, because we know that for this aspect of medication treatment, a lot of new medications and new methods is coming up to the market. But this is really hard for hospitals to choose which one to be included in their lists. So before this access inside the hospital, patients always need some new medication if they fail on the prior ones. So what we're doing right now, another thing is we establish a platform to help this patient to get the right agents as they need it if they got PD on their prior program. So there's a kind of information system to support new agents access. And this platform also supports community services via pharmacy clinics. And this platform also can kind of give patient care as follow-ups of education, this kind of calling and call-out center for them to give them support. So there's something we're trying to change the access problems, because right now the budget is always limited in all over China and in any kind of hospitals. I think this is also something should happen in all over the world. Okay, so last for summary, that I should say that patients with our HSCT are known to have a very complex pharmacotherapy. Pharmacists are kind of integral member of MDT team, aiming to ensure safe and effective care in preventing and managing drug-related problems. In my talk, I highlight some of this. But we can do something to prevent and to manage drug interactions, is for sure, and developing policies on prophylaxis to prevent any kind of ADRs and providing education to improve medication adherence and various transition of care. Beside of this, I want also add this points to my talk is, as we can see from several slides, that more efforts we need to do and more attention to be offered to patients after discharge, especially after we are experiencing COVID-19 years. And patients monitoring and supportive care needed to be more active via community clinics to help more patients. Research on sensitive signals should be taken out because this indicates safety issues is really important. And access of novel agents and services should be a better option. If we can do this, it's a better option. So this is all for today. Thank you very much. Thank you for your patience. We can really take a little of the questions. Thank you very much.
Okay, thank you very much, Dr. Yu. And as a chair, I have to thank you all three speakers, Dr. Dry, Dr. Ho, and Dr. Yu, for the excellent talk. Now we come to the end is a question and answer for our session that the highlight of pharmacy aspect in transplantation and cellular therapy. I would like to invite our three speakers to open their camera and microphone. Yes, I will have a look. If the audience have any question, you can type in the Q&A in the box, and after that, I will ask the question for you. And Dr. Dry, Dr. Ho, you have any question to discuss with each other? You are very welcome. And let me begin first, as you both are a special pharmacist in the BMT unit. As a doctor, as a transplanter, I always have a problem with the calcineurin inhibitor, and as you both are the special expert in this field, anything in your experience or anything about you want to aware the doctor and the transplanter about the calcineurin inhibitors, since it have some quite of the drug interaction, and anything to be aware? What is your point to want to tell us today? Please, maybe we can begin with Dr. Dry, and after that followed by Dr. Ho. Yes, please.
Okay, thank you for your questions. From my experience, I think is the most thing that we should aware is the drug interactions. Maybe we don't know about it. For example, like azole
Yes.
and the PPI, for example. I think it is the mainly thing is the interaction with the medical devices, for example, like PVC containing efficient set. Have you ever heard that? Because of the cyclosporin can absorb to the PVC set, as can reduce the serum level of the patients. Yeah, and the another thing that I want to comment is the time periods that we should measure the calcineurin inhibitor level. I think it's not like the precise consensus about how many days, how many doses that we should measure. But for my experience, we should quite wait for a while. For example, like for 2 or 3 days after we change the dose of the calcineurin. Yeah, this is for my opinion. Thank you.
Okay, thank you, Dr. Dry. Dr. Ho, how about your experience that probably about the calcineurin inhibitor to be aware in the transplantation unit, please?
Hi, everyone. Nice to meet you at APBMT conference. I agree with everyone that actually in our transplant population, drug-drug interaction is a real problem because our patient has a very complex pharmacotherapy, and drug interaction with azoles, with phenytoin, which is a CYP3A4 inducers, they are a real problem when it comes to TDM of calcineurin inhibitors. So at SGH, we actually do a quality QI project where we look at starting a higher dose of intravenous cyclosporin in this group of patients receiving phenytoin for seizure prophylaxis for busulfan-based kind of conditioning regimen. And we found that actually a higher proportion of patients are able to achieve a therapeutic cyclosporin level by the time of day 0 of stem cell infusion. So I think it's something that we can consider in our transplant population in the event that if phenytoin is used in combination with calcineurin inhibitors, we should consider starting on a higher dose of cyclosporin.
Okay, thank you very much. So the next question is about the CAR T-cell prevention for the infection. Dr. Ho, you give us a very comprehensive review and experience in Singapore. The question is about the CMV infection in post-CAR T-cell. is there any evidence for the anti-CMV like the letermovir prophylaxis in post-CAR T-cell therapy? Or do you have any experience, or you say that right now the evidence is only preemptive, as you mentioned? Thank you very much.
Thank you for the question. But I think the use of letermovir as CMV prophylaxis in the CAR T population is really lacking in evidence. I'm not aware of any studies that recommend the use of letermovir in this setting, so I will not be able to comment much on this practice.
Okay.
But we still use letermovir in our transplant, allogenic transplant patients who require it.
Okay, thank you very much. Yep. So the next question is about do you preemptive cut tacrolimus by 75% when initiating posaconazole or less, assuming tacrolimus level is already within range? I think they asked about if you give tacrolimus after GVHD prophylaxis and the level is in range, and you want to add the posaconazole as an antifungal prophylaxis, do you cut the tacrolimus 75%, or what is your approach in your experience? Maybe I can begin with Dr. Ho and after that followed by Dr. Trai, please.
I think it is reasonable to consider cutting tacrolimus when patients are starting on posaconazole, because we anticipate posaconazole to increase the level of tacrolimus. But in practice, I would suggest that we look at the trend of the tacrolimus as well. If patient levels are subtherapeutic to start with, then we may not need to cut preemptively. So I agree to cut, but we also need to look at the trend.
Okay. How about Dr. Trai? Do you agree, or you have any comment on this?
I agree with Dr. Ho, but if the tacrolimus level is already within range, maybe I will cut, but not too much, not cut for 75%. I think it's too much, because of if we, in my practice or my experience, we likely to concurrent the posaconazole with the calcium inhibitors. When the patient started the conditioning regimen, and then day +1, we likely to concurrent the posaconazole with the calcium inhibitor as well. That means if we change, I think for the question, I think I'm not sure. They want to ask about if we convert the tacrolimus from the oral to intravenous to oral. If you want to ask about the conversion to IV to oral, I agree to cut the posaconazole. Cut the tacrolimus dose maybe about for 50 to 75%. Yeah.
Okay, thank you very much. I think Dr. Trai, you have give us a drug interaction about the phenytoin and busulfan. Everyone all know that the busulfan may have a seizure and it maybe have a drug interaction with the phenytoin, and phenytoin level is a problem. What do you recommendation about the anti-seizure prophylaxis in this case from your experience and your review? Yep.
I quite recommend, as I presentations, I quite recommend levetiracetam, because of I concerned about the drug interactions of the phenytoin for another drug. For example, like cyclophosphamide, for other anti-epileptic drugs, for example, like the NK1 receptor antagonist, there's the phenytoin can affect too. I think it's this for my experience. I found many patients who receive the phenytoin, they happen very, drowsiness. Okay, that means I quite recommend to change the to levetiracetam to seizure prophylaxis. Yeah.
Okay, Dr. Ho, you have any advice or experience on the anti-seizure prophylaxis if the busulfan going to use for the conditioning regimen and we need to have a seizure prophylaxis, or any recommendation from your point? Thank you.
I agree with Troy that Keppra is a attractive drug to consider for anti-seizure prophylaxis, given its favorable drug interaction profile. But in Singapore, in SGH, we don't really adopt the use of Keppra because most of the studies using busulfan-based conditioning were conducted with phenytoin.
Yes.
So if we would want to use Keppra as an anti-epileptic medication, then I would consider to do it if we are able to support busulfan TDM in our center. So at this point in time, in SGH, we are still using phenytoin as anti-epileptic medication. But moving forward, eventually when we are able to support busulfan TDM, then I think Keppra will be a drug of choice to consider.
Okay, thank you very much. I think we come to the end of our session. As a chair and the APBMT 2021 Scientific Committee, I would like to grateful thank you for Dr. Dry, Dr. Ho, and Dr. Yu for a great presentation, and especially Dr. Dry and Dr. Yu for the Q&A session that I think I and all the audience have learned a lot. And thank you very much, and hope to see you next year for another APBMT meeting that will be held in India. And for the audience, this will be the meeting for General Assembly in this room, and we have the interesting lunch symposium that you have to move to meeting room number A. And at last, I would like to thank all the scientific committee and all the speakers for this session. Thank you very much.
Thank you. Bye-bye.
Bye-bye.
Bye.
Okay. Good afternoon, ladies and gentlemen. So welcome to this. Let's see. Kurika. You can see that. Welcome to the General Assembly. So I am the Shin Okamoto and the chairman of the executive board in HM-Speak and blood marrow transplantation. So Minako, please show the agenda today.
Yes.
So this is the agenda for today's General Assembly. So we have one hour. So let's move on. The first is I would like to invite the Professor Altit, Congress President, to explain about the APBMT 2021 preparation, the content and status, and etc. So please, Altit, it's your turn.
Thank you, Professor Okamoto. Dear all, the Thai Society of Hematology feels an honor to receive the opportunity to host the 26th APBMT Congress on October 15 to 17, 2021. And again, I would like to extend our warm welcome to all of the delegates. Next slide. And here is the list of our local organizing committee, comprising of multi-generation of Thai hematologists and transplanters. Next slide. We planned the Congress as a hybrid conference, having a high hope that we can welcome some of you physically in Chiang Mai. Even in June, when we had a surging COVID wave from the Alpha variants, we felt that we still had some chances. But the arrival of Delta waves changed everything. And we had to change the plan to host a totally virtual Congress in July. We have to admit that this had a lot of impact to our planning. Luckily, all of our speakers are so kind. They agreed to join us virtually, and we do not have to change our program much. However, we still miss seeing you in person, miss a chance to show our hospitality or even the flag handover ceremony that we did every year. Next slide. Next slide.
Sorry, it can work.
Thank you. So the virtual platform was provided by our local virtual platform vendor who has experiences in managing virtual conferences using Zoom webinar features. And if permitted by the speakers, the content can be viewed for 2 months after the Congress. Next. As of today, there are 707 delegates joining us from more than 25 countries and territories. Next slide. There are 21 pre-Congress topics, 53 education topics, 12 oral scientific communication. There are 53 renowned speakers joining us in this Congress. Next. At this moment, I would like to thank APBMT Executive Board and Scientific Committee for their support and advices we have received. This collaboration has made our Congress much better. I also would like to thank all of the sponsorship that make this happen, and I hope you all enjoy the Congress. Thank you.
Thank you very much, Altit. And I think the meeting has been very successful. And then on behalf of the all participants, and I'd like to thank you, you and also two scientific committee chair, Professor Hongan and Professor Van Orsait, and other members of organizing and scientific committee members. Thank you very much. You have prepared a wonderful meeting. Thank you. So now we move on to the next issue. That is new scientific committee and emeritus members. We are now pleased to announce that we have now the new 2 scientific committee members. One member is Dr. Shalat Damador, as he is from Bangalore, India, and also Dr. Xiao Liansai is a Taiwan Veteran General Hospital from Taipei in Taiwan. They are selected for to the new scientific committee members. And then also, I would like to share the name of the new emeritus members. Those are the Professor Ko-Min Chen in Taiwan, and also Professor Min Yao in Taiwan too. These two members has organized the annual APBMT annual congress in the past, I think the 2008 and 2018. So this is deserved for this great honor. So Dr. Damado and Dr. Yansai, welcome to the scientific committee, and I'm looking forward to working with you in the future. From now on, thank you very much. And then next issue is the standardized way to organize APBMT annual congress. If the Alok is here, the Alok Srivastava is the current vice chairman of the executive board of APBMT. Alok, would you like to give a talk on this? Yes, please.
Thank you, Shane, and good morning, good afternoon, everybody. So we have been discussing the way in which the annual Congress should be organized for some years now, mainly from the perspective of making it easier for the organizers if there is a more standardized format, and also for the participants to know what to expect where, as we have come to expect in other major scientific meetings in the world. So this effort has been ongoing for the last 5 or 6 years almost, and there is a reasonable standardization already in terms of the day on which it starts, the day on which it finishes, the overall structure, but some variations keep happening. So the executive board and yesterday with the scientific committee, we had some discussions, and these are the summaries. So, you know, I will not read them, but I will just summarize them quickly to mention that in future, starting from last year, it's the APBMT central organization that is responsible for organizing this meeting, along with the local country host, the local society. The organizing committee will have co-chairs from the APBMT board, could be the chair of the board or a nominee, and there will be a co-chair from the host country, and other members will be nominated in equal numbers to the organizing committee. The scientific program committee similarly will have 2 co-chairs, one from the host country as well as one from the executive board, and they will have members both from the local society as well as international members. The next one, please. The scientific program, I don't want to read this, but basically we'll have a standard starting and finishing time so that people would know well in advance how this meeting will run. An added feature now is a half a day of a standing committee as well as working group meetings that precede the scientific program. It was easy to organize it online, virtually, last 2 years, this year and last year. How this will work out in live meetings, which we hope to do next year, we will see. But this is the way we hope to have better attendance at these meetings and more, more meaningful discussion, because the 1 hour in the middle of the scientific program was certainly not enough for some of the standing committees. Also, the program will have multiple tracks. It will cover both educational aspects as well as scientific advances. We have tried to now develop thematic sessions. One of the reasons is that we would like to have the speakers contribute a short review of about 1,000 words from their talks, and these will be combined for each session into a review article that will reflect the state of the art of that aspect of transplantation at the moment. And these then will become publications in the blood cell therapy, as our chief editor will soon let you know. So that's the way the scientific program is to be organized. The next one slide, please, Minako. Yeah, we also want to make sure that there is a fair bit of standardization in the way speakers are selected, that there is adequate representation for the Asia Pacific regions, and the number of speakers from different countries. So there are some suggestions for that, and we will see how we can follow these. One other important learning lesson for us this year and last year has been that the virtual meeting provides very good access to many people, many more people than were able to come to the physical meeting. So even if we shift to the physical meeting, I think we need to continue to make access available through the virtual platform. So in future, most meetings around the world are likely to be hybrid meetings, and the APBMT meeting should be similar. And the final point is about the funding support. In the last slide, Minako, please.
Sorry, I cannot. We cannot.
Okay, fine. So I think that's the general plan that we wanted to let you know about for the meeting that will happen for the APBMT Congress. Thank you, Minako.
Thank you, Alok, for the very clear presentation. Actually, we have discussed this new approach at the business meeting yesterday, and then this approach has been approved by the scientific committees. So we would like to follow this format from now on. And as Alok mentioned, there's several advantages by using this format. Because we have more participants, and hopefully more people who is going to lead the next generation of APBMT. And also, as Alok mentioned, it's very easy to make more sophisticated educational materials by using this video recording presentations. So there are so many advantages. So I'd like to follow this route and looking forward to how it will be translate to further progress over activity of APBMT. Okay, thank you, Alok, again. And then we have to move on to the next issue. That is report from the executive board. That is for me. And then this is the current executive board members. I've been chair this board for more than 8 years or more, I guess. And also my greater set of Dr. Alok Srivastava is also serving as a vice chair of the executive board of APBMT. And besides that is David Ma from Australia, Kifan from China, Ami Hamideh from Iran, John Wook from Korea, and William Yankee Wang, Singapore, is also actively working in the board as a board members. Next, yes. So we have already discussed about issue number 1 and number 2, and this is number 3 of the membership. And this is the current status of the APBT membership. Before 2009, we have 89 members, and then recruiting slowly but steadily, and maybe 10 to 15 new members each year. But it's over the last 3 or 4 years, its number to decline a little bit because of the, I guess, COVID-19 pandemic. But so total, we now have 210 members. And then there is a category, as a variety of a category of members. But as a chair of APBMT, in order to facilitate future activity, we do need many members, especially from younger generations. Generations take over our generation. So I very much encourage all of them to actively participate to the APBMT activity as a member. Okay, thank you. And then this related to the APBMT membership, that is, we do also have the joint ASTCT and APBMT dual membership. You can be a member by paid as AST $150. You can also be the member of ASTCT. With that, you can have a lot of advantage, free access to their journals or the many others. So this is very good and convenient. So we do have this kind of membership. So please consider to be the member of APBMT and then try to get this dual membership. Thank you. And then, although of course the executive board members is working so hard about fostering the activity of APBMT, but also we collaborate with other HCT societies on the world. For example, from September 2020 to September 2021, we participated in the Harmonizing Definition Task Force. It's led by the Nicholas Kruger as EBMT, is currently president of that society. And then we picked up several topics and then discuss about the definition of these categories, such as graft failure, for example, or reduced intensity, for example. And then we try to harmonize this way. This is kind of like the good example of the global collaboration of 4 major stem cell transplant society in the world. And as many members participating in to this project as the member of steering committee, as well as a member of each working group. Also, William is from Singapore, is one of the members of EBMT, executive board, is participating in EBMT COVID-19 summit. And also, we participating in the survey on cancer immunology in Asian countries from Japan. And with that, we can get the more clear information about which drugs or cell therapies now available among Asian Pacific countries and regions. And also survey for presentation of quality and accreditation for cell therapy, a global perspective. Excuse me. It is activity of WBMT. We also present survey and in this workshop, and then share the information with other transplant societies. So this kind of, we are also active to participating in this kind of global activity. Okay, the next 2 issues will be presented by the editor-in-chief of Blood Cell Therapy, APBMT Official Journal, Dr. Akatsuka, and also for the APBMT Center Standard is presented by the Dr. Alex Silverstava. Okay, so before that, yeah, Midako, sorry, it's move on to next is your turn.
Yes.
Sorry, let's go ahead.
Is it okay?
Yes.
So on behalf of the editor-in-chief, Dr. Akatsuka, I report about the blood cell therapy. So as of October 20th, we received 22 submissions to blood cell therapy, and at the end of this year, we expect to receive 30 or more submissions. As Dr. Srivastava mentioned that blood cell therapy launched new issue this year called Special Edition to increase the articles in blood cell therapy. Articles are categorized in state-of-the-art and were created from selected presentations at this annual Congress. The first edition has just published on October 14th, including articles ready for publication timely, and articles which were not in time will be published in issue 4 or in the subsequent issues. The articles were initially checked by guest editors and then reviewed by associate editor and editor-in-chief. Special acknowledgements to the guest editors were written on the top page of each manuscript. This time, Dr. Akatsuka and Dr. Srivastava made great contributions as guest editors. Thank you very much. Editorial Office applied to the PubMed Central this September. We are in the initial screening now and will receive the final decision by next spring. To pass the screening, periodical publication is mandatory, so we need a lot of articles to publish. Thank you. That's from editorial office.
Thank you, Minako. So as Minako mentioned, we do need more paper on this journal. So please, I encourage you to submit a lot of papers too. And now I'm pleased to announce that this year VCT award. So this award is this year is selected three authors, and then it will be carefully and extensively discussed in the editorial board, and they come up with three awardees. Minako, next please. Yes, these are the three nominees, awardees. Prize number 1 goes to the Minako or Ida for their publication on late mortality and causes of death among long-term survivors after autologous hematopoietic stem cell transplantation. The second prize goes to Takahiro Sato, excuse me, Day Zero bone marrow pathology of allogeneic hematopoietic stem cell transplantation, which is a novel prognostic factor in myeloid malignancy. And the third award goes to the treatment of relapse after leukemia by LHC plus donor lymphocyte infusion using CD30 for positive reserve at the time of allogeneic transplantation. So congratulations of these three members for your great achievement. Okay, so finally, as I mentioned already, we were very much looking forward to submission to PCT. It's a growing journal that we could foster their growth more and more. So thank you. All right, the next one is a report from APBMT Data Center. And so Dr. Yukari, Ms. Yukari Nakao, please.
Thank you. So I report the brief result of our activity survey performed in 2019. Left slide shows the number of all types of hematopoietic cell transplants. And in 2006, it reached 10,000. And in 2016, it was beyond 20,000. In 2019, 27,394 transplants were performed. And right side shows trends in allogeneic and autologous transplant. Number of transplants by allogeneic transplant exceeded 17,500, and number of autologous transplant exceeded 9,800. Next slide shows trends of related and unrelated transplants. Number of transplants by related donors exceeded 11,700. And number of transplants by unrelated donors exceeded 5,700. Until 2010, there is a real difference between number of related and unrelated, but in recent years, Number of transplant by unrelated donor is more than double related donors. And trends in haploidentical transplant on right. Number of transplant by donor sources of haploidentical is increasing rapidly in recent years. And in 2019, the number of haplotransplant is more than 6,900. And this time, 21 countries and regions and 703 centers cooperated with this survey. So the more detailed results of activity survey this time is on our website. You can browse the two-click research and APBMT registry on menu bar as shown on this screen. And also the member of APBMT can download complete data at the bottom of this page. We would like to appreciate cooperator in Asia Pacific made effort collecting this survey. Thank you so much for all your cooperation. Finally, I informed every member and cooperator to schedule of next activity survey. You can report number of transplant performed in 2020 year. We will start it around late November, and deadline will be set January 31st, 2022. To close report from data center. Thank you for your attention.
Thank you. Thank you, Kari. HCT performed in 2029. No, 2020. Sorry.
I'm so sorry.
Very sorry.
Yes.
Okay, thank you, Yukari. You're moving too fast, but we're still in 2021. But anyway, thank you very much. Okay, let's move on to the next one as a report from Registry Committee by not Yoshiko, but Minako this time, please.
On behalf of the chair of the Registry Committee, Dr. Atsuta, I report its activities. This Thursday, the Registry Committee held 2 sessions titled HSCT Activity in the Asia-Pacific Region and Registry Management and Research. They were very successful sessions with nice presentations. The Registry Committee held the web conference bi-monthly, discussing the revision of official documents such as detailed rules of data usage and authorship, or participation in the international multiple myeloma study, and so on. From the Registry Committee, one paper focused on the results of the Activities Survey 2016 was published in Blood Cell Therapy. The committee will continue to make efforts to collect activities and outcome registry data. We also prepare for next publications focused on the results of 2017 activity survey, as well as by using some data from outcome registry. We will continue to have bi-monthly web conference. Thank you.
Thank you, Minako, for your presentation. So what's next? Oh, yes, this is back to Dr. Srivastava. Your turn. Update of APBMT Center Standard project, please.
Thank you, Dr. Okamoto. So you will recall that we have been discussing about having APBMT defined, accepted standards for HSCT centers in our region. So towards that, to cut a long story short, instead of developing our own standards based on what different nations were following, we decided 3 years ago to adapt the JC 7th edition, which had 3 levels of accreditation available, made available for centers to gradually move towards full accreditation. And we modified that, had a discussion with JC, and got permission from them to share that modified version with the executive board as well as the scientific committee. Now, our plan proposed last year in the General Assembly was to conduct a survey to find out what is the current norm of standards being followed in different countries and regions within the APBMT. So this was a very short questionnaire that was sent out to selected people from different countries and regions to obtain an overview of what was the current practice in our part of the world. In the next slide, what you see is the data. So the good thing is that out of the 20 countries or regions that reported, out of the total number of 22, 70% are following some standards. Those standards are mandatory by local regulation in 50% of these countries or regions, and they are optional in the rest. About a quarter, 30%, are following international norms. They may have adapted it to their requirements, but they're international norms, while the others are following more country or institution specific norms, but they have some definition. And then we also have, what percent of centers are following this, and it was very encouraging to see that in most of the 70% of the countries or regions that are following standards, another 70% are of all the centers. It's not just only a few centers. So the summary of this data collection was that there is good awareness already of the importance of defining and following standards. What we hope to do in this coming year is to extend this in a little more depth in each country, contacting either the hematology or the transplant society or the Ministry of Health to see what is their acceptance, what is their inclination towards implementing norms more formally in each country. And we will be getting in touch with all of you in different ways, trying to reach to all the registered centers to see what the situation is and how the APBMT can help in helping you to adapt and adopt the modified JC format in a way that is practical in each country. I will stop there, Shin. Thank you.
Okamoto-sensei, mute です。
Sorry. Thank you a lot for the nice presentation. All right. Let's move on to the next issue. Report from Nuclear Accident Management Committee. So, which has to be done by me. Okay. I'm not the expert, but okay. This committee is led by the Dr. Nail and Dr. in India, and also Dr. Hyo-Rak Lee in South Korea. And they've been doing a great job. And now, next slide, is that guideline has been working for over the last several years on the guidelines, and then draft guidelines were now approved, and after due process by the APBMT Executive Board. And so now the guidelines for medical management or nuclear radiation emergency is now available on the APBMT website. So please go to the website and take a look. And then this is a slide from Dr. Nail. It's the way to forward of this Nuclear Accident Management Committee. So she's planning to have the vital workshop in 2022, and also they're looking to considering the nuclear accident registry in the future. So they are anyway so active, and we will expecting to have further activity on this committees. Thank you. So next is this is kind of the fun part of this General Assembly. It's a presentation of by the host country for the 27th Annual Congress in 2020, that is India. So Alok, this is your turn again.
Thank you, Shin. And, it's a great pleasure on behalf of the Indian Society for Blood and Marrow Transplant for me to share with you some details of the meeting that the APBMT General Assembly, Scientific Committee, and the Executive Board has very kindly agreed to allow us to host. You will recall that we were supposed to have a physical meeting in India in 2020. That was decided in 2019. Unfortunately, the pandemic with COVID-19 changed everything. So we did have a hybrid meeting. And then we allowed the decision that had happened earlier about 21 being in Thailand to continue. And then the Executive Board and the Scientific Committee was very kind to allow us the opportunity to hopefully hold a physical meeting. We are very, very hopeful given the situation in the world, the situation in our own country, with very, very high % of people getting vaccinated and, this illness, becoming less and less of a problem, that we will be able to hold a physical meeting. But as I was mentioning earlier, this is likely to be a hybrid meeting. We would like as many people as possible to come to the country and enjoy the interpersonal interaction during the scientific meeting, and as well as the tourism and the hospitality. But for those who cannot make it, there will certainly be a virtual online component as well. So in terms of the date, it is 6th to 9th October 22. The place is the same that we had chosen 2 years ago in Kochi in Kerala. The next slide will show you that it is fairly easy to reach Kochi from the whole of Asia Pacific, as long as you can reach Singapore, Thailand, Bangkok or Kuala Lumpur. It should be possible for you to take the next hop to Kochi. And from the western part of the world, from either North America or Europe, as long as you can reach hubs in Middle East, either Dubai, Abu Dhabi or Doha, you will have the next hop to Kochi. The next slide just shows you where, the red arrow shows you that it's at the, western coast, beautiful coast actually. It's one of the top tourism spots in our country. And the next slide again just shows you that it's in easier way how we can reach Kochi. There are many airlines that serve the airport, the international airport there. Again, reminding 6 to 9, the actual conference will be in an international convention center attached to the Grand Hyatt Hotel. There are many more hotels in that area, both in the star category and as well as more affordable accommodation available within 5 to 15 minutes from this location. We will be having transportation arranged already for people to come in the morning and go back in the evening. There are other modes of public transportation for you to come and go from the venue. And with that, I think we go to the last slide just to show you the various facilities at the convention center, which is a fairly new one at this place. The next one. Yeah, as I mentioned, apart from the scientific program, we will of course have many opportunities to look around. Kerala is famous not only for the beach, but also the backwaters and all the coconut plantations and many cultural and culinary activities. So, we hope that many people will be able to come there. Thank you.
Thank you Alok, for the nice presentation. The Kochi certainly looks like a wonderful place for meeting, of course. So I encourage all of you to participate in the next India meeting, the virtual, right? And I remember that in 2020, we have the record number of participants in India meeting. It's close to exceeded 1,000, something like that. So 1,400. So it's amazing. So I very much expected to see many people of those. And then unfortunately, the people who could not come to this area, but please, I hope they are access to the meeting in a virtual way. So thank you very much, Alok. It's a nice presentation. So we now come to the end, and I have one news to report to you. The APBMT office has recently received the sad news. Professor Honorata G. Bailon, he's a former scientific committee member, has passed away in December 2020. As shown in the slide, Professor Bailon has been working so hard at the early stage of APBMT as a scientific committee members, and she also participating actively at the APB activity survey. And in addition to that, Professor Bailon has been spent so much time on the fostering the activity of her own country in the Philippines. So we really miss a great loss. But good news is there are so many trainees of Professor Bailon is now actively working in the Philippines and supporting to the activity of APBMT. So that is I'd like to share with you at the end of this General Assembly. So this is the all things I prepared for today's General Assembly. Does anyone have any additional discussions or report? Please feel free to raise your hand. If not, we still have 13 minutes. But if you're not any further discussion or questions.
So, Shin, I think everybody is not on this. This is a different kind of platform, so they may have to put their comments in the Q&A. I don't think everybody is on the same. This is like a webinar where some of us are on the.
I see.
Everybody is not on the. They may be, so they may have to. We can check with the organizers. No, they may put comments or questions like a scientific meeting. Everybody is not on this platform.
So if there is any Q&A on the platform, the organizer will copy and put that in the chat box.
Okay.
Thank you. Oh yes.
There's no question. Okay, fine.
Okay, good. Oh, so many people, I hope, listen to this General Assembly. I thought only 12 people here, so I'm a bit disappointed, but it's not good. Okay, thank you very much for participating in the General Assembly, and please go back to the meeting and enjoy the rest of the meeting. Thank you very much for your participation again. Thank you, Alok. Thank you, Aldit, for your participation.
Thank you.
And
thank you.
Minako, Yukari, thank you very much for your great support. Thank you.
Thank you. Bye.
Bye now. そうか、これ難しいんだね、先生。ここには出ないんだ。
We can start now.
Okay. First, I would like to welcome all the attendees this afternoon to listen to this very meaningful topic, the practical points on nursing care in bone marrow transplantation. So we have 5 speakers this afternoon. So I'm the chairman of this session. So I'm Godfrey Chan from University of Hong Kong, Queen Mary Hospital, and also Hong Kong Children's Hospital. And my co-chair is Utip Lavalang from the Faculty of Allied Health Science, Pharmachet, University, Thailand. And so the first speaker will be talking on the central line care. And then I would like to introduce her. Wait, I will get her CV. Please wait for me. So the first speaker will be Latari Jungwan Nicha from Thailand. So she graduated from Mahidol University, and subsequently she got her master's degree. And she has been the BMT coordinator and nurse for almost like 28 years from her CV. So it's a very experienced expert in this area. So she's the nursing officer in charge right now, and she has been studying in Johns Hopkins University and Nebraska University and Chulalongkorn University. So without further ado, we'll listen to Latari Jungwan Nicha. Please.
Hello everyone, I am Latari from Thailand. I'm giving a presentation under the topic of Update Guideline of Centralized Care of Vascular Access Device. Life cycle of vascular access device is started from day 1 of the insertion until the last day, which is removal day. So along the vascular access device journey, there is a lot of interventions we have to focus on. And I will share some standards which I get from INS Standards of Practice 2021. There are 11 standards related vascular access device care and management, and I will go through one by one. I'm going to start with hand hygiene, which everyone also keen on. For me, if I have to explain the importance of hand hygiene to our staff, I would like to deliver a speech about the importance of doing a little things from U.S. Navy Admiral William H. McRaven, which giving a speech of change the world. If you want to change the world, start by making your bed. If you make your bed every morning, you will have accomplished the first task of the day. It will give you a small sense of pride and will encourage you to do another task and another task. And by the end of the day, that one task completed will have turned into many tasks completed. So, if you cannot do a little thing right, you will never be able to do the big things right. The challenge is we have to sort it out to find a simple way to our staff to get an understanding of step of hand hygiene. They need to know when they have to perform the hand hygiene, how it can be returned to the habit. Like they can perform the hand hygiene before and after contact the patient, after contact the body fluid, after touching the patient's surrounding, like bedside, like IV pole, or before moving the works on the soiled body side to clean body side at the same patient, or before, during, and after procedure requiring ANTT. That's an example. Not only for healthcare provider, patient and relative involvement is also important. So we have to educate and train them and ask them to observe our care provider. So patient and relative have their own right to speak up if hand hygiene is not performed during the patient's care. For aseptic non-touch technique, or NTT, is originated by Lowley in the late of 1990. So there are 5 practice items of using aseptic non-touch technique. One is a key site. which is any portal to entry to the patient, such as vascular access device site or open wound. The second thing is a key part, which is a part of procedure equipment which prone to contaminate, such as syringe tip, male lock, needle, the outlet of three-way or spike of IV set. First thing is general aseptic fill. Most common is a tray to pull all medication, syringe, or IV start kit. This is an example. Fourth is critical aseptic fill, which is sterile drapes and all sterile supply upon the drape. The last one is microcritical aseptic fill, which is a small things cover a key part like IV cap. This is an example of what I explained earlier to make it easy for understanding. Next standard is about compounding and preparation of parenteral solution and medication. For the organization which able to have a single dose medication prepared by pharmacists, so you are so lucky because I really know that there is a super protocol like clean room ISO class 10,000. There's a contamination engineering control ISO class 100 and complete PPE for preparation process. However, if parenteral medication and solution have to prepare outside the pharmacy environment, so we have to adhere to the safe injection practice when preparing all those things, and I will tell you more. For the safe injection practice that I told you earlier, they are focusing about adhere to aseptic non-touch technique when preparing a medication. So use medication package as a single dose or single use for each patient. And we have to discard a single dose vial after a single entry. So that's it means like 1 for 1, not 1 for all. And if there is a multi-dose, we should dedicate a multi-dose vial for that particular patient. We have to keep a multi-dose vial for up to a maximum only 28 days. Disinfect the vial septum before each entry and also clean the neck of the glass ampoule with alcohol 70%, and also use a new needle and syringe for every injection. Next standard is a flow control device or IV pump. Okay, when we select, make sure that it was set easy to plumb and load, and easy to titrate flow rate, and also the key information visible on one screen. And also we have to visual indication to show pump is infusing, or easy to view battery level, easy to view pressure level, and pump lightweight and easy to transport. Also, the selection of a flow control device is based upon factors including the prescribed infusion therapy, rate control requirement, infusion-related risk, patient care setting, and available resource within the organization. However, administration set with anti-free flow mechanism are used with electronic infusion pump. For the IV filtrations, we consider infiltration of solution and medication. The reason to use that one is to reduce the microbubble of the air which will be mixed in the infusion solution and medication. The second one is if you want to reduce the particulate matter like the small particles from the IV mixture that will be affect in the critically illness patient, like patient in ICU or even our patient as well. And for the peripheral venous catheter, that filtration will be reduce the incident rate of phlebitis. And we have to select a proper type of filtration. So there are two types of that. One is for a clear liquid, which is a 0.2 micron, and a second one is 1.2 micron filter, that for parenteral nutrition containing nutrient admixture or fat emulsion. And however, there's another things that quite challenge in Thailand because the product is not popular. Yes, it's about the filter needle or filter store that we're gonna use to withdraw any medication from glasses and input to get rid of a small particle. I'm going to talking about the vascular access device segment. The first one is a adhesive segment device or ASD. That one is an adhesive back device that adhere to the skin with a mechanism to hold the vascular access device. And there is another separate dressing over the adhesive segment device. So both dressing and this device have to be removed and replaced every 7 days. The other thing is about the integrated segment device. This is a device that combines a dressing and segment function, include a window so we can see the site, and there's a broader fabric collar with built-in segment technology. This one is quite new for me and is not available yet in Thailand. Next standard is about needleless connector. Needleless connector are used to connect syringe and or administration set to vascular access device hub or other injection site to eliminate the use of needles and reduce risk of needle stick injury. We have to understanding the characteristic of needleless system which are available in your organization, because it's really related with flushing and locking technique. For example, needleless connector with negative displacement is allowed but reflux into the vascular lumen. So when we do a flushing, we have to use a technique as flush, clamp, and disconnect. This is an example. The key point of needleless connector is we have to adhere to aseptic non-touch technique, and needleless connector upon disinfection are key part and cannot be touched except with another key part like the tip of IV tubing. There's a question about disinfection. Use passive or active disinfection. So active disinfection is used a vigorous scrub of 5 or 15 seconds with antiseptic. And passive disinfection is like a cap, provide a physical barrier with a disinfectant agent. We put it on, leave it there, and once we need to access, just open it and let it dry. However, a study comparing active and passive, both are effective. For flushing and locking standard, they will focus on using a single dose system for our vascular access device, flushing and locking. Do not use IV solution container like IV bag as a source of, for obtaining flush solution, and use the minimum volume equal to twice of the internal lumen volume, but it depends on organization policy. For me, I might use 3 ml for peripheral and 5 ml for centralized. However, the large volume like 10 ml may remove a fibrine or the dark precipitate in the lumen. And use positive pressure technique to minimize bodily reflux. You can use a prefused syringe design that prevent this type of reflux. When we flush, recommend to use a pulse type push and pause technique. And we can consider for the locking, even we can use either preservative-free 0.9% normal syringe or heparin 10 ml, 10 units per ml. It depends on organization policy. For vascular access device assessment, care, and dressing change, for transparent dressing, we have to change every 7 days or immediately if it becomes soil and damp. For the neonate, dressing change can be changed as needed due to the risk, including catheter dislodgement, patient discomfort, or skin injury. But if we put on the gauze and tape, it must be changed every 2 days. While perform the dressing change on vascular access device, we have to using either standard ANTT or surgical ANTT based on risk assessment. And if we have the dressing kits, it will be improved the time efficacy. So you can select the type of dressing, even sterile gauze or even transparent dressing. And also you have to use a segment method to stabilize a secure vascular access device. For the chlorhexidine impregnated dressing for all patients 18 years and older with short-term for non-tunnel vascular access device, and it may be benefit for arterial catheter or other vascular access device when all other CRAPC prevention strategy have proven ineffective. And we have to use with a caution among patients with a fragile skin and all complicated skin pathology. And we have to monitor for erythema or dermatitis at the dressing site if we decide to use it. I will go for administration set management. We have to teach non-clinical staff, patient and caregiver not to connect or disconnect administration set to prevent misconnection. And we have to trace all the catheter, administration set or add-on device between the patients and the solution container to vascular access device before connecting or reconnecting at each care transitional or move to a new setting or new service. So for the tracing is a part of handoff process. Primary and secondary continuous infusions. We have to replace primary and secondary continuous administration set that administer like clear solution, no more frequency than 96 hours, but at least every 7 days. But if secondary administration set or IV set is disconnect from the primary set, the secondary IV set is now considered a primary intermittent IV set, and it needs to be changed every 24 hours. This is a new standard that was launched this year about catheter-associated skin injury. This is an occurrence of drainage, erythema, and other cutaneous abnormality, include vesicle, bulla, erosions, or tear at a vascular access device site in a dressing area, which persists 30 minutes or more after remove the dressing. To reduce the severity, the vascular access device site must be routinely assessed for signs and symptoms of skin injury, and if it happens, the appropriate intervention should be implemented. Many risk factors for skin injury, such as age, malnutrition, hydration, or radiation therapy. Therefore, the way to prevent allow skin antiseptic fully dry before place the dressing, or use skin barrier product for skin protection. And when they apply the dressing, we have to apply without tensions or pulling or stretching. And when we remove dressing, make it slow and keep the dressing horizontal to skin at 180 degrees. And if the skin injury was occur, wound care specialist should be involved if no improvement within 3 to 7 days. This is an algorithm about catheter-associated skin injury. If we help our staff to have an effective assessment and proper management for each situation, even skin injury, skin irritation, and it includes an alternative skin antiseptic as well. Summary of vascular access device and care management tips is about protect ourselves from and patient by focusing hand hygiene, stick on standard precaution and transmission-based precaution like PPE. For the dressing, we have to maintain an intact dressing over vascular access site, and also dressing removal protocol, site care, and replace regularly, and ensure that the securement method is appropriate. Assess a skin regularly to identify a risk factor of catheter-associated skin injury. And once patient at risk, skin protect and prevention must be intervened. And also put an aseptic non-touch technique as a priority for vascular access device management, and address on competency of clinical related vascular access device care and management. Thank you for your attention, and you can find me at nuturi@bangla.com.
Thank you, Nuturi. So let's move to the second speaker. The topic is about transplantation complications. The speaker is Miss Lim Yan Ying. Her biography: she's a nurse manager at the Children's Cancer Center, KK Women and Children Hospital, Singapore. So let's continue with Lim Yan Ying, please.
Hi, a very good afternoon. I'm Yan In, a nurse manager from Pediatric Oncology and Transplant Unit from KK Women and Children Hospital in Singapore. Today, I'll be sharing about 3 common transplant complications and some of their nursing considerations. I'm sure the first complications we are going to talk about will be familiar for all of you. Mucositis is the most common and one of the most distressing complications among transplant patients, which can adversely affect their quality of life. The transplant treatments such as chemotherapy, radiations can cause inflammation and ulcerations of the mucosa lining along the entire GI tract, which is further aggravated by myelosuppressions and GVHD complications. It is usually characterized by severe pain that can extend from the mouth, throat to the abdominal and anus. Such discomfort can affect nutrition and alter the fluid and electrolyte balance, all of which can increase the risk of infection. Nurses play an important role for mucositis assessment. We need to consider what are the type of conditioning regimen that will give us some information of the risk of developing mucositis, such as patients with TBI, melphalan, and MTX regimen will have a higher risk of getting mucositis. Daily oral and perineal examination should be performed to assess the progress of mucositis development. Evaluate the oral intake and output, as well as initiate dietitian referral promptly can also optimize nutrition during transplant. Daily weight and monitoring will help us to assess the fluid loss. Pain assessment is also vital, as we know it is inevitable in patients with mucositis. And lastly, looking out for early signs and symptoms of the mucositis will allow timely initiation of intervention. Grading oral mucositis using a standardized assessment tool is a good communication tool among healthcare professionals, as it helps to assess the progress of the oral mucositis and effectiveness of the intervention. The most commonly used will be the NCI tag for mucositis. As mentioned earlier, nurses should perform daily examination of the oral mucosa, observing for any swelling, erythema, ulcer, plaque, pain, and grade accordingly. Educating patients on mucositis and empowering them to self-assess and report their symptoms are also highly encouraged, as this may improve patient self-management and adherence to the recommended oral care protocols. Having an established basic oral care regimen is one of the most important nursing considerations. It is aimed at maintaining good oral hygiene to prevent oral complication. There is currently conflicting evidence on the best oral care regimen to be used in the transplant population, and it is recommended to use a multi-oral agent protocols that is beneficial for the prevention of oral mucositis. The avocation of toothbrushings are getting more attention on the last decade. Many literature has suggested that pancytopenia is no longer a contraindication, but we will have to be cautious in those group of patients. Use a soft bristle toothbrush with mild fluoride toothpaste is recommended. Not forgetting to mention, for the adult population, regular cleaning of the dental prosthesis are also required. Blend rinse like normal saline can help to clear the oral debris. Some centers will use concurrently with sodium bicarbonate, which help to balance the pH of the oral mucosa and can help to dissolve mucus and debris, which promote oral hygiene. Cloxidine mouthwash is a good choice for antiseptic property to reduce the microbial load, especially during neutropenia phase. Local anesthetics such as lignocaine spray and mouthwash may be useful for pain control and bring comfort to the distressing symptoms. However, it should be avoided in the pediatric population in view of the potential adverse reaction. Lastly, not forgetting the lip, which dryness and cracked lip are usually the first sign of mucositis. We will always recommend patients to lubricate the lip and lip balm liberally and as frequently as possible. Pain control is an important element in mucositis management. Starting pain control promptly can significantly improve the experience of the patients and reduce the stress caused by the complication. Treatment may be adjusted accordingly to the patient response to first-line treatment. We can see an example here of our pain management for oral mucositis in pediatric oncology setting. We usually start off with a milder analgesia, such as paracetamol, and start to morphine quite quickly if it does not help. In our experience, IV morphine is usually quite effective in reducing pain control by mucositis, and we work closely with our pain team colleague to optimize pain regimen and keeping our kids as comfortable as possible. Within the transplant context, oral cryotherapy for short infusion melphalan and 5-FU is probably the only interventions that have strong evidence in reducing severity of oral mucositis. Fortunately, it is low cost and easy to implement. The patients can swallow our sheet for 30 minutes, starting 5 minutes prior to melphalan administration. For pediatric patients, we also try to be creative by offering like ice popsicle, fizzy drinks, which can help to improve adherence to this intervention. Dietary management in ensuring adequate fluid intake and well-balanced diet is also vital in mucositis management. Encouraged fluid intake can keep oral mucosa moist, and adjustment to the food consistency, such as feeding soft, bland, and moist food, may be more tolerable. Spicy food, hot temperature, dry and rough food, as well as sugary and acidic food should be avoided, as this can cause discomfort and may even promote dental caries. Also, to consider changing oral medication to IV as much as possible. In summary, the key nursing considerations for mucositis will include an accurate assessment of the oral cavity, individualized plan of care depending on the risk level, the conditioning regimen, and patient factor. Initiate timely preventive measure with basic oral care regimen and deliver prompt treatment when mucositis develop to reduce discomfort and further adverse oral complications. The next complications we are going to look at is hemorrhagic cystitis. It is a condition in which the lining of the bladder becomes inflamed and starts to bleed, and the blood can be usually seen in the urine with our naked eyes. Hemorrhagic cystitis is likely to be multifactorial, caused by conditioning regimens such as radiation or chemotherapy, in particular the cyclophosphamide or ifosfamide. It can occur early during or within 48 hours after the end of the conditioning regimen. Viral infection, commonly the reactivation of BK viruses, as well as other viruses such as CMV, adenovirus, HHV6, can also cause hemorrhagic cystitis. Patient cytopenia and alloimmune response may all contribute to this complication. In terms of nursing assessment, it is important for us to look up and educate patients on the signs and symptoms of hemorrhagic cystitis. This include dysuria, increased urine frequency, bladder spasm, which usually present as intermittent lower abdominal pain and hematuria. Some diagnostic investigations will include ultrasound, which may show bladder wall thickening and presence of clots. Urine investigations are required to rule out infective cause. For nursing considerations, many centers practice preventive measures using hyperhydration and MESNA for high-dose cyclophosphamide. MESNA will bind with the metabolite known as acrolein released by the cyclophosphamide and deactivate the metabolite to prevent bladder wall irritation. With the combination use of vigorous hydration, it will reduce the exposure of bladder mucosa to acrolein and other toxic metabolites. During the days of hyperhydration, the patient has to be closely monitored for fluid balance, including weight at regular intervals. The patient should also be assessed for any urinary or lower abdominal pain or discomfort. Many patients would describe the pain as intermittent and colicky, which can be excruciating that comes and goes. Smooth muscle relaxants such as oxybutynin can help to relax the muscles and also to provide comfort. When clots start to form within the bladder, a urine catheter has to be inserted and regular or continuous bladder washout can be initiated to prevent bladder obstruction. Unfortunately, in severe cases, cystoscopy may be performed. Increasing the platelet threshold may reduce bleeding, and patients often require regular red cells and platelet transfusion. Systemic antimicrobial drugs such as citalopram and ciprofloxacin can be started if hemorrhagic cystitis is attributed to BK or adenovirus. To also note that the use of tranexamic acid is contraindicated in hemorrhagic cystitis due to the risk of clot formations and retention. Sinusoidal obstruction syndrome, in short SOS, is also previously known as venous occlusive disease. It is a complex disease due to the toxic metabolite being produced by the hepatocyte as a result from conditioning regimen, leading to damage and inflammation of the endothelial cells. Early-stage mild SOS may not be particularly well recognized since the symptoms are subtle. It may not require treatment and spontaneously resolve within a few weeks with a good supportive care. Unrecognized SOS may, however, progress, sometimes very rapidly, into moderate or severe cases, and severe SOS is associated with multi-organ failure and a high mortality rate of approximately 80%. Therefore, in order for SOS to be successfully prevented, identified, diagnosed, and treated promptly, nurses play an essential role in assessing and monitoring for early detection and providing timely supportive care. Every patient must be identified pre-transplant, and it is important for nurses to be aware of all the risk factors before transplant, as stated in this table. You can see those risk factors that are bold text will be the most relevant and good to keep in mind. These include older patients with higher baseline bilirubin level, presence of iron overload, which is commonly seen in groups that have high frequency of blood transfusion, receiving drugs such as genmotuzumab, inotuzumab, ozorgymycin, or progesterone. We do know that allogenic transplant with myeloablative conditioning regimen, such as those that include busulfan, fludarabine, and the use of combination CNI, tend to have a higher risk of SOS. By identifying the risk factor will allow all possible supportive and treatment measures to be established before transplant. Nurses should also be particularly proactive with those patients identified as high risk and alert the team at the earliest suspicious of complications, as it is critically important to the overall clinical outcome. Typically, the clinical manifestation of SOS will include hepatomegaly, weight gain from baseline, ascites, and a rise in bilirubin level, all of which are part of the classical Seattle and Baltimore criteria to diagnose SOS. However, over the years, many literature has argued that it is hard to recognize early or mild cases of SOS before it progresses to a more severe form, using this tool for both the adult and pediatric population, as it lacks sensitivity and specificity. These signs and symptoms are often subtle and make it difficult to differentiate from other transplant complications. The most recent diagnostic criteria proposed by APBMT for adult remain the same as the Baltimore criteria for early onset SOS that occurs within the first 21 days. Hyperbilirubemia is a mandatory criteria with presence of at least 2 of the clinical symptoms. Late onset SOS are rare in adult but has been reported, and thus the development of the late onset SOS criteria was established by the group. Although hyperbilirubemia and jaundice are rarely absent in adults with classical SOS, it is less observed when developed later, and therefore it is longer mandatory in late onset SOS. And the diagnosis may be made if patients fulfill a less stringent criteria of Baltimore criteria. As for the pediatric population, the criteria acknowledge the differences in various aspects of the disease between children and adults, such as early onset of consumptive and transfusion refractory thrombocytopenia are observed in children with SOS. And rising bilirubin level may not be as common as it is in an adult, and therefore not made as a mandatory criteria. Also, as pediatric patients can develop SOS after 21 days, there is no time limit for diagnosis of SOS among children. For us as nurses, the care, information, and support provided at bedside is extremely important. Different institution monitoring protocol may vary, but patients undergoing transplant often follow a strict monitoring protocol before, during, and after hospitalization. This protocol may not be focused on endothelial injury, but is generally fundamental in helping to picking up signs and symptoms of early SOS. In the literature, many of the European group have come together in publishing consensus paper regarding monitoring guidelines. The paper by Warner et al. That's published in 2016 was quite helpful to draw a clear recommendation for SOS assessment and monitoring. They also emphasized that it requires multidisciplinary effort, with nurses playing a central role. The intensity of monitoring should also be adapted based on the patient's risk level and accordingly to the clinical severity. In baseline assessment, assessing vital signs is part of the general nursing assessment. and other more specific SOS assessment is aligned with the diagnostic criteria as mentioned earlier, which include trending the patient weight, measuring abdominal girth and liver size, inspection of skin, sclera, and abdominal, and monitoring of any new development to platelet refractories. Monitoring frequency may be intensified with adding on intake-output charting, monitoring of the additional lab investigation to assess the renal and liver function. And we can't emphasize enough that supportive care remains the key to managing the early phase of SOS. Such assessment will allow us to identify the abnormalities of the trend and implement timely intervention. Next, we will discuss some practical nursing consideration for nursing SOS patient. Fluid imbalance is usually the earliest sign for SOS. We might need to consider concentrating IV and maintain a strict IO. Transfusion of blood product and albumin are usually preferred over the free fluids like normal saline, as it can help to maintain the intravascular volume and renal perfusion. We must also be mindful that endothelial damage in SOS can result in third spacing like ascites, and therefore a positive balance or increase in weight may require some gentle diuretics to maintain a good fluid and electrolyte balance. And as pediatric patients are more sensitive to diuretic and susceptible to fluid loss, we usually start off with a combination of oral spironolactone and oral furosemide and may progress to continuous IV furosemide depending on patient response. It is also important to continually monitor the progress of the ascites, usually with the assessment using ultrasound and measuring the abdominal girth. Peritoneal drainage and assisted ventilation may even be required in severe cases. Ultrasound will also be useful to confirm hepatomegaly, ascites, and to rule out any differential diagnosis. The reversal of port venous flow are specific to SOS, but often only seen in the later stage. Nurses are often the one who draw blood from the central line and responsible to monitor the trend of blood count, liver and renal function, and to promptly alert the medical team of any abnormal result. Also, coagulation study will be crucial when patient is on defibrotide. The patient's medications should also be reviewed to avoid hepatotoxic medications, and dose adjustment may be required for nephrotoxic drug to reduce renal insult. Patients with SOS would likely to have their abdominal discomfort and pain that can affect their ADLs. Frequently assess pain level and assist in pain management will increase the patient's quality of life and experience. In terms of SOS prophylaxis and treatment, ursodeoxycholic acid or ursodal are the most widely used as an SOS prophylaxis. The only challenge is that it is only available in oral formulation and may be quite challenging to ensure patient compliance. Defibrotide is the most promising drug for treatment of SOS so far and has been used for prophylaxis in high-risk group. Patients on defibrotide should have a baseline coagulation profile that is trend, and the platelet threshold should also be kept higher than usual to reduce bleeding tendency. While mucositis and hemorrhagic cystitis are more general complications as a result of cytotoxic therapy, SOS complications are more specific to the transplant population. Therefore, nurses in the transplant unit have to be trained and equipped with knowledge and skills about SOS diagnosis, assessment, and management. A SOS is very much a clinical diagnosis. Educating patients regarding SOS can encourage self-assessment and reporting of symptoms. Assessment of HSCT patient with an established set of monitoring guidelines will also allow the early detection of symptoms associated with SOS. Once SOS is developed, management will focus on supportive care, managing the signs and symptoms of disease. Treatments such as defibrotide will be administered, all of which is to prevent the development of the end outcome of multi-organ failure. Thank you very much once again to the APBMT Organizing Committee for inviting me to speak. I'm happy to take any questions if there's any.
Okay, thank you, Ms. Lim. So we will leave the questions at the end of our whole session. So the next speaker will talk on a very timely topic about the transplantation coordination in the COVID-19 era from the Australian perspective. So the speaker will be Annabelle Horn. So initially, she started her career in London, United Kingdom, and maybe due to the sunshine, she moved to Sydney in the year 2000. And then she has been engaging in the nursing aspect of bone marrow transplantation for the past 25 years. So she's currently the BMT coordinator at St. Vincent's Hospital in Sydney, Australia. So Annabelle, the floor is yours.
My name's Annabelle Horn. I'm from Sydney, Australia. I am the bone marrow transplant coordinator at St. Vincent's Hospital. Thank you for asking me to speak today. I'm going to be talking about blood and marrow transplant coordination in the COVID-19 era, and I'm going to be outlining some of the challenges and changes in the Australian bone marrow transplant landscape since the pandemic. At St. Vincent's, our bone marrow transplant program was established in 1975. We are the second largest bone marrow transplant program in the state of New South Wales. We're certified by the Australian Bone Marrow Donor Registry as a transplant, apheresis and bone marrow collection centre. And our laboratory and apheresis service have accreditation with the National Authority of Testing Association. We are currently working towards FACT-JC accreditation. We undertake approximately 50 allogeneic and 35 autologous transplants annually. Of the 50 allogeneic, the majority would be from unrelated donors, probably about 2/3 would be from unrelated donors, and the remaining 1/3 would be from family donors. There have been many changes, of course, since the pandemic started in early 2020. One of the most significant changes is that stem cells from unrelated donors now need to be cryopreserved at cell source or at collection source and sent via air freight. This is true of donors in the other states of Australia, and of course it's true for overseas donors. This has led to delays for patients and some new logistical challenges for laboratory and coordination staff. There's been an increased workload for the registry, for the transplant coordinators, and for the scientific staff, and some new ethical issues have emerged as a result of these changes in practice. I'm going to illustrate some case studies, present some case studies to illustrate the impact of these changes on individual patients. Australian international borders shut in March of 2020, and that was really the start of the lockdown measures in this country. My first case is a man aged 40 with acute myeloid leukemia. He was in first remission, having had an induction on 2 consolidation chemotherapy cycles. He was planned for a transplant from a Polish donor on the 19th of March last year, using a myeloablative regimen of busulfan and cyclophosphamide. He was admitted to hospital to start conditioning on the 11th of March. On the 14th of March, European borders shut. This meant that his freshly collected donor stem cells could not be transported as planned. Instead, they were sent from Poland to Germany for cryopreservation and then sent from Frankfurt to Sydney via air freight. His transplant protocol was amended, resulting in prolonged hospitalization and consequently time to engraftment. As you can see here, he had received 3 doses of busulfan when borders closed and ended up having 6 rest days. During this time, he was supported with blood products and antibiotics as needed. He eventually went ahead with the remainder of his conditioning regimen and had his transplant eventually with using the cryopreserved cells on the 24th of March. As you can see, there was a very satisfactory cell dose of 8 × 10⁶ per kilo CD34 positive cells. To date, this patient is well. He has had some graft versus host disease of the skin and the eyes. This has been treated with etanercept and a weaning dose of prednisolone. He has a normal full blood count and normal liver and renal function. He's generally well and tolerating medications. So despite this delay in the donor cells and using the cryopreserved cells, his outcome to date has been good. Since this particular case, All donor cells from overseas registries have been cryopreserved and sent to us via air freight. And different registries have had some different protocols or standard operating procedures. This has increased workload in our laboratory, with the donor cells, of course, being stored in our stem cell tanks upon arrival, with the resultant increased use of liquid nitrogen and other supplies. And the use of cryopreserved stem cells has had an impact at the bedside, with an increase in the number of bags of donor products for infusion, which means the infusion takes longer, and the risk of DMSO reaction and toxicity, which of course we don't usually see in the allogeneic setting. We enter all of our adverse events, such as DMSO reactions, into a document-controlled quality management system called QPulse. We review these incidences quarterly, and we've noticed a significant uptick because of using cryopreserved cells in the allogeneic setting. The different laboratories having the different processes and different standard operating procedures. At the beginning of the pandemic, when we were just starting out using the cryopreserved cells, we found that sometimes there was miscommunications and misunderstandings. So we developed this list of information requests, and of course other centres around the world did exactly the same thing, just so that we could communicate ahead of time and all be clear about what we were wanting and able to provide. So we always ask for cryopreserved cells to be divided into at least 2 bags. We prefer the cell concentration in the final product to be less than 300 times 10 to the 9 per litre white cell count. Due to the delays in shipping, if possible, we like the cryopreservation report sent to us before the product is shipped. Sometimes the freeze curve is sent with the product, or sometimes that can be sent afterwards. We request the cryoprotectant mix information, and we ask the overseas laboratories to specify the final DMSO concentration. The description of the inventory is very useful. What bag type, whether they're using overwrap bags, and what type of cassette the unit is being stored in, because different cassettes, sometimes we're not familiar with them, so it's good if we know in advance of the different type of cassette the product's coming in. We ask whether the product is coming in liquid or vapor phase, and of course we want the data logger record for the duration of storage and transit. We ask for information about the processing environment. We ask about whether ISBT labeling is in use, and what licensing or accreditation does the laboratory hold. I think this is important because in many overseas countries, the stem cell collection service isn't necessarily the cryopreservation service. Sometimes cells are collected in one place and sent to another place for cryopreservation. So there's a lot more communication between laboratories, hospitals, and transplant centres. We ask, of course, for the microculture results to be sent to us when they're available. Of course, they're not usually available at the time of shipping, depending if the product is subject to quarantine, and some registries have quarantine requirements and some don't. The second case occurred late last year. This lady was 52 years old, and she had peripheral T-cell lymphoma with associated hemophagocytic lymphohistiocytosis, and that had been diagnosed in the middle of last year. She was in complete first remission after chemotherapy with CHOAP and dexamethasone as per the HLH-94 protocol. She had a fully matched unrelated donor in Poland. The donor was requested, and of course we requested cryopreservation. This was to be done in Germany, and then the product was going to be shipped to us. The German registry has a quarantine requirement that cells cannot be shipped for 10 days after they have been collected and cryopreserved, and this led to the product arriving a bit later than we had initially thought. Sadly, the patient relapsed just before conditioning was due to start. She was admitted to hospital for a salvage chemotherapy regimen, but unfortunately her disease did not respond to treatment and she died. The donor cells were discarded in accordance with registry policy and of course our local hospital policy, and this really highlighted a new ethical issue which has emerged since the pandemic, because now it's not very uncommon for donor cells to be collected and cryopreserved but then not used because the transplant is cancelled due to relapse. And this has happened several times in our centre, and I'm sure, well, I know it's happened in many other centres too. The third case is a young man, aged 30, Philadelphia positive B-cell ALL with complex cytogenetics. His induction chemotherapy was with the graft protocol with dasatinib, and he was in morphological remission. He had a well-matched German donor. Of course, cryopreserved cells were requested, and his transplant was planned for January. Unfortunately, the donor became ill with COVID. The transplant had to be delayed by 5 weeks, and we sought guidance from the World Marrow Donor Association and followed their guidelines, as did the German registry, of course, about ensuring the donor had recovered from COVID before proceeding with filgrastim mobilization and apheresis. For the patient, there was consideration of giving him further maintenance chemotherapy. However, he had a repeat bone marrow aspirate and trophine, and molecular monitoring was done of his disease, and it was felt that he could have a break from treatment just for this 5-week delay period. He had the standard cyclophosphamide and total body irradiation protocol. He had a good cell dose, as you can see, and his cells were infused on the 25th of February this year. To date, he remains well with no specific issues. He has no symptoms of chronic graft versus host disease. He has just recently commenced his post-transplant vaccines. Our vaccine schedule has been amended to reflect the pandemic, and now COVID-19 vaccine, influenza vaccine, and pneumococcal vaccine are prioritized for patients, and other vaccines are given after those vaccines have been given. This young man has sadly experienced a significant deterioration in his mental health, particularly in recent months with the very prolonged lockdown in Sydney due to the Delta strain outbreak. His mental health issues are being managed by his GP, and it's certainly true that mental health services have been utilised much more since the pandemic, and there are some more government-funded programs available. Often these are via telehealth, but this man's GP has been seeing him in person, I think just to undertake more of a welfare check, because this young man unfortunately is spending a lot of time alone and finding that quite hard. And there are online programs available for mindfulness and helping people cope with the pandemic and changes. Case 4 was a young lady aged 42. She was a Japanese citizen but living permanently in Australia. She had Philadelphia positive ALL, diagnosed in March of last year. She had had a stormy course in her induction with some ICU stays with recurrent subdural hematomas. She had an HLA matched sister in Tokyo, and we had to work out how best to obtain the cells from her HLA matched sister. We looked into trying to get them collected in Japan, but that wasn't able to be facilitated. She had the medical examination and baseline blood screening in Tokyo, and then we made plans for her to travel to Sydney. The visa application was very lengthy. The flights to Sydney were very difficult to secure because there are passenger caps on the number of international arrivals. And upon arrival, she went straight into 14 days hotel quarantine, which is a requirement for everyone arriving into Sydney at the moment. The donor assessment and consent process was lengthy and protracted due to the limited availability of in-person interpreters, but eventually she completed the donor workup process and was assessed by an independent hematologist, which is routine at our centre. The apheresis was complicated by hypotension, citrate toxicity and anxiety. However, sufficient cells were collected for transplant. The patient remains well. Her most recent BCR-ABL is undetected and her GVHD has settled. She was recently admitted to hospital with cellulitis and a fall in blood count. This may be a combination of the dasatinib and perhaps the infection. Her prednisolone dose is weaning, and she'll have her BCR-ABL checked next month. But she's generally well and in good spirits and back to enjoying family life with her children. There's been many practice changes since 2020. I think some of the most significant changes for the patients have been the use of telehealth. More than half of appointments now are done via telehealth. Much less staff see patients on ward rounds. Ward rounds are done virtually, and only a small number of key clinical staff see the patient in person. So I think that's been different for patients. They're seeing perhaps just one consultant hematologist per week rather than seeing their own individual hematologist, so just so that we reduce the number of staff on the ward. Visiting hours are extremely restricted at the moment. There is no hospital visiting at all. And we've put in some different things to help patients feel more connected to their families, making sure that, for example, the relatives are on speakerphone when the doctor examines the patient, which gives the family member a chance to ask questions when the doctor is there with the patient each morning. The cryopreserved donor cell infusions, as I've said, have resulted in much longer infusion time on transplant day and an increased incidence of DMSO reactions. Of course, we pre-medicate all the patients to try and mitigate that. Some of the practice changes for the staff have been mandatory temperature check upon arrival at work and QR code check-in systems, virtual meetings and education sessions. Since the onset of the Delta outbreak, we are fit tested for the N95 mask, whichever one is most suitable for the staff member, and we wear a visor with patient contact. The COVID vaccine is mandatory for all healthcare workers in Australia, and if it's possible to work from home, staff are encouraged to do so. The past 18 months have been a challenging time for us all. The pandemic has certainly accelerated the use of virtual healthcare platforms, and I expect some of the use of telehealth is here to stay. The cryopreservation of unrelated donor cells at collection centre has presented unforeseen ethical issues as well as a great many logistical and communication issues. Some of the increased infection control measures in the broader community have reassured patients and families who feel very vulnerable. People wearing masks, social distancing, hand hygiene. These in some ways have helped patients, and so I think there has been some good changes and some things that have been very challenging for all of us. And thanks very much for having me to speak today.
Thank you, Annabelle. Let's move to the next presentation. The topic is about home care and follow-up after hematopoietic stem cell transplantation. And the speaker is Professor Amaro Marie Lucas. Her biography: she's a professor and head of the unit Hematology Oncology Nursing at the College of Nursing Christian Medical College, Vellore, Tamil Nadu, India. Professor Amaro Marie Lucas, please.
Good morning and warm greetings from Christian Medical College, Vellore, from India. As we all know that HSCT or allogenic stem cell transplantation is a complex procedure which involves replacement of diseased marrow with healthy donor hematopoietic stem cells. Bone marrow transplantation is the main mode of treatment for many hematological malignancies and genetic disorders. Patients after HSCT are at high risk of developing complications due to the conditioning regimen and radiation. Nurses have a crucial role throughout the phases of hematopoietic stem cell transplantation. And this is the pictorial representation of allogenic HSCT process. I just wanted to review this, and because I am in the end of the presentation, that is home care management and preparation of patients for follow-up. So preparation for discharge, this is the protocol which is followed in our institution. The patient's absolute neutrophil count should be more than 1,500 cubic millimeter. Platelet count should be more than 20,000 cubic millimeter. Patient should be normothermia at least for 48 hours and no signs of GVHD. This may vary from institution to institution. Home care instructions. How do we prepare the patient for managing at home? So when the patient is ready to go home, the patient and family is prepared mainly to keep the house clean using disinfectants. Also, we tell them to use hand hygiene regularly, change clothes every day, check body temperature twice a day for the at least first 100 days of transplant, avoid crowded places, social gathering, and also we advise the patient to use face mask while outdoors. Also, the patient should avoid contact with pets, fresh flowers, plants for 100 days, persons with active infections, children immunized with live vaccines in the last 6 weeks, chemicals such as paint thinners, and nail polish remover. Also, we tell them to keep visitors to a minimum for the first 100 days. Visits should be very brief, and we tell them to ask the visitors to wash hands before meeting. The second aspect what we concentrate is on nutritional management. So we advise them to eat homemade, freshly cooked food, take small frequent meals. In case of nausea, we tell them to take prescribed antiemetics, antacids 30 minutes before food, and eat high caloric protein, vitamins, minerals, and fiber rich diet. And we tell them to take milk products once diarrhea settles. Take thick-skinned fruits like banana, pomegranate. Drink boiled cool water, at least 3 to 4 liters per day. Also, we tell the family to use hot water for cleaning the vessels. Cook and serve food with great care, like the person who is preparing and serving food must be free from infection, and food need not be prepared separately from the rest of the family. What are the food restrictions we tell them? Foods from restaurants, raw vegetables, salads, thin-skinned fruits, unpasteurized milk, milk products, cheese and curd, moldy and outdated food products, herbal and traditional nutrient supplements. Also, we tell them to not to take alcohol and carbonated beverages. But the personal care is very important to prevent infection. So we tell them to take shower daily with a special attention to the axilla and groin using a mild soap. Use baby oil or mild skin lotion for dry skin, and do not share towels, face mask with the family members, and use an electric razor for shaving to avoid injuries. And also we tell them to keep nails short, avoid exposure to direct sunlight for first 6 months, especially patients who had TBI as conditioning regimen. Mouth care is equally important. So we tell them to inspect the mouth daily for sores, ulcers, bleeding, and white patches. And we ask them to use antiseptic solutions, especially chlorhexidine. In our setting, we advise them to use for mouth rinse 4 times a day. If patient has any sore or burning sensation, we advise them to use sodium bicarbonate solution for mouth rinse, and use soft brush for cleaning the teeth. Also, we advise them to use fluoride content toothpaste and moisturize lips with lubricants. Eye care is important. We tell them to watch for dryness, tearing, and blurring of vision. So if patient has any complaint of dryness, we advise them to use artificial tears, which will reduce the dryness for patients. And wearing dark glasses can help in case of light sensitivity. And we tell them to avoid contact lens if possible to prevent infection. Perineal and anal care is important. So we tell them to watch for burning micturition, rectal bleeding, fever, and wash thoroughly with mild soap and water after urination and defecation. Avoid constipation to prevent rectal mucosal injury. This can become the source of infections. So we advise them to take high fiber diet, plenty of fluids, regular exercises, stool softeners, laxatives as prescribed. And also we advise them to use clean inner garments. The fourth aspect what we pay attention is the CVAD management, central venous access device management. Very often our patients in our setting, we discharge them with the central venous access devices. So weekly dressing change and flushing of catheter is required, and we advise them to use a waterproof wrap over the central line while taking shower. If the central line gets wet, the dressing has to be changed. The catheter may be removed when the patient shows steady engraftment and is clinically stable, or when infection is suspected. Watch the catheter site closely for redness, induration, itching, pus discharge, and report immediately to the catheter clinic. Activity and exercises are important, but we still tell them to avoid strenuous exercises, and we encourage them early morning walking, aerobic exercises daily, maintain ideal body weight, and take adequate rest and sleep is important. And the other common problem or maybe a serious complication what usually the patient has is the chronic GVHD, which is a very serious complication after allogenic hematopoietic stem cell transplantation. So these are all the symptoms the patient can develop in the skin. So we advise them to watch for redness, rashes on the palms and hands, especially dryness, itching, tightness, skin thickening. In the GI system, if they have any loss of appetite, dysphagia, nausea, vomiting, loose stools, melena, abdominal cramping, weight loss. Also in the mouth, they need to look for any dryness, redness, white patches, sores, taste changes, and also any yellow discoloration of the skin, eyes, nails, and dryness, irritation, burning, itching, photosensitivity of the eyes. And also if they develop any dyspnea, fatigue, cough, joints, tenderness, stiffness, tightness. So these are all the manifestations they can develop as a complication due to chronic graft versus host disease. So what are all the medications the patients will be sent? So we tell them to stick on to the prescribed medications at the specified time. Also we teach them about the side effects. So there are two groups of drugs the patients will be on. One is immunosuppressants. So immunosuppressants, we advise them to take immunosuppressants before food as prescribed, and especially with a cyclosporin capsule, we tell them to open the foil pack and wait for a few minutes to prevent nausea, vomiting. And if it is syrup, we advise them to mix the cyclosporin syrup in fruit juices, but still they need to avoid grape juice. And immunosuppressant assays to be monitored. The duration, frequency, side effects of cyclosporin are reinforced to both patient and family. So these are all the common side effects the patients can develop, like hypertension, seizures, paresthesia, flushing, acute kidney injury, hypertrichosis. If they develop any of these manifestations, they need to report to the physician. Also, the patient will be sent on prophylactic antimicrobials. So we advise them to take prescribed medications at the specified time. So the common drugs are antibiotics. Mainly we give them Pentid, Septron, antiviral with acyclovir, antifungal with fluconazole. So prophylactic antibiotics will be continued till the use of immunosuppressants for 1 year, but prophylactic antiviral and antifungal drugs to be given for 100 days post-transplantation. If at all the patient needs blood support after the transplant, after the discharge of the patient, we advise them that they need to remember that only irradiated blood products using filters to be transfused after transplant. And also we advise them to wear a medical alert tag stating irradiated blood products only. This is very important to prevent deterioration of GVHT. Also, we tell them when to report and where to report. So report immediately to Hematology Emergency Service in case of the following complaints if patient develops. Like fever, temperature more than 100.4 degree Fahrenheit, chills, shivering, cough, fatigue, or any signs of infection, problems with the central line, if there is a pain or any discoloration at the central line site, loose stools, severe vomiting, bleeding, hematuria, melena, sudden severe headache, sudden abdominal pain, jaundice, seizures, blurring of vision. So if they develop any of these complaints, they need to come to the hematology clinic or daycare service immediately. So what are all the aspects we need to remember? Why post HSCT follow-up is important? The purposes of follow-up, one is mainly to adjust the drug dose, and second is to monitor chimerism and analysis, and third is to monitor for delayed complications. So these are all the main reasons why follow-up is very important for the patients after HSCT. So frequency of follow-up. So this is the protocol we follow in our setting. We advise the patients to come for follow-up once a week for 1 month, once in 2 weeks for 2 months, 100 days evaluation, once in 3 months for next 6 months, and once in 3 months for next 2 years, once in 6 months for next 3 years, thereafter once in a year. So what are the nurses' role during follow-up? We have a special nurses, they are called BMT nurse coordinators. So they have a great role they prepare the patient and donor during pre-transplant period and during the transplant preparation of patients and donor for HSCT, but they have a big role in the long-term management of patients after transplant. So what are all the components of follow-up? We do it when the patient comes for follow-up. One is we do the assessment, mainly the physical assessment of the patient, investigations and special tests, immunosuppressants, chimerism monitoring, CMV PCR monitoring, catheter site care, treatment of specific infections, treatment of GVHT, and the last one is immunization. So in the assessment, the BMT nurse coordinators are they see the patient when they come for follow-up. So they do head-to-toe examination like patient's height, weight, eyes, oral cavity, chest, abdomen, liver, spleen, skin. Examination is done. Also, they need to watch for GVHT and post-HSCT complications. Patients' vital signs are monitored like temperature, pulse rate, respiratory rate, blood pressure, and oxygen saturation. The nutritional pattern also are assessed like appetite, nausea, vomiting, intake of food, calorie assessment. Bladder pattern, like if they have any dysuria, hematuria, bowel pattern, whether the patient has any diarrhea, melena, constipation. All these assessments are done by the BMT nurse coordinators when patient comes for follow-up each time. So what are the investigations we do? We do a common routine investigations like complete blood count, creatinine and potassium if patient is on cyclosporine, liver function test, random blood sugar if patient is on steroids, immunosuppressant assay. Especially we advise them when the patients present with increased creatinine, blood pressure to adjust the drug dose or to change the immunosuppressant. And we advise them not to take the immunosuppressant before sampling. Some of the special investigations what we do is RT-PCR, RQ-PCR, and ABO titer, especially patients and the recipient ABO mismatched transplant. The immunosuppressants, how do we really taper the immunosuppressants in the absence of GVHT? And patients with non-malignant disorders like aplastic anemia, thalassemia major, and other genetic disorders, the patients will be given full dose of immunosuppressant for 6 months. Thereafter, the drug will be tapered for next 6 months and stopped at the end of 1 year. Patients with the CML, patients are given full dose of immunosuppressant for 3 months, and second 3 months tapering of the drug is done. Follow at the end of 6 months the drug will be stopped. Patients with ALL, AML, and MDS, the full dose of immunosuppressant is given only for 1 month, and tapering is done for 2 months. Thereafter the drug is stopped. So the common immunosuppressants we use in our setting are cyclosporine, tacrolimus, mycophenolate mofetil, sirolimus. The next important aspect during follow-up is chimerism monitoring. So what is this chimerism monitoring? This detects the presence of donor cells in the bone marrow or in the peripheral blood of HSCT recipients. So chimerism quantifies the donor and recipient cell proportion present in the recipient at any moment following transplant. Chimerism reflects the response to treatment, and it correlates with the risk of malignancy, relapse, or graft failure. So always successful outcome, it is always associated with a state of complete chimerism. So if patient shows complete chimerism, the monitoring is done on day plus 28, day plus 60, plus 100, and after that once in 6 months, and followed by after 1 year, and repeated based on the patient's clinical status. If patient shows mixed chimerism, the chimerism analysis is done very frequently. So what are the types of chimerism? Complete chimerism, where the patient hematopoietic cells are entirely donors cell in origin. Mixed chimerism is both donors and recipients hematopoietic elements are detected. Split chimerism, where you cannot even identify whether it is lymphoid or myeloid components. There is lack of harmony in origin of cells. The next aspect is CME PCR monitoring. We do on day plus 28, day plus 60, day plus 100 after the transplant. If patient shows negative, the result is negative, we continue prophylaxis with acyclovir till 100 days of transplant. If patient has positive result, that is if copies are more than 100,000 copies per ml, usually the patients are treated with ganciclovir 5 microgram per kg twice a day till negative status is achieved. Higher viral load, or if patient has low WBC count, the alternate drug is injection artesunate. The dosage is children we give 2.5 milligram per kg per day and adult is 120 milligram IV OD till we achieve the negative result. The catheter site, the central venous access site care is very important. So generally the patients will be on either Hickman's catheter or triple lumen catheters. The most commonly used catheters for patients undergoing transplant is double lumen Hickman's catheter, and this can be in place for a few months in the absence of complications. So the exit site dressing is very important. We do in our setting till the catheter is removed, the dressing once a week, and every time when the dressing is changed, we watch for any pain, tenderness, erythema, and immediately that will be reported to the physician. Also, we assess the line in situ. That is, every time the catheter line in situ is assessed, swab to be sent for culture if any pus discharge is present. The observations made during the dressing are documented in the CVD record. Catheter is removed prior if patient shows stable engraftment or signs of infection. Also, we concentrate on treatment of specific infections. During the follow-up, if patient develops any infections like infection with BK virus, they're treated with the cidofovir, leflunomide, ciprofloxacin, and infection with herpes simplex virus treated with acyclovir. Varicella zoster, again they are treated with acyclovir. Fungal pneumonia treated with voriconazole. Clostridium difficile, they are given metronidazole, and oral vancomycin. So these are all the common infections are expected after 100 days of transplant. So again, the other important complication is GVHT. Patients present with GVHT, that is delayed or chronic GVHT, and they are treated with methylprednisolone, basiliximab, ruxolitinib, mycophenolate mofetil, sirolimus, tacrolimus, and cyclophosphamide. Sometimes when the patients are not responding with cyclosporin, these are all the other alternate drugs can be used for treating GVHT. The next aspect what we concentrate is immunization schedule. The immunization schedule, what we do is 1 year after BMT, that is if there is no GVHT or the patients are off immunosuppressant, then with the doctor's consult the immunization is given. So immunization, usually we start with them with tetanus toxoid 0.5 ml per 0.5 ml and inactivated polio vaccine and pneumococcal vaccine 1 dose. But tetanus toxoid and inactivated polio vaccine, that is injectable, 3 doses are given, and pneumococcal vaccine and Haemophilus influenza, and usually they are given 1 month in a difference between the time duration between tetanus and polio vaccine. The other optional vaccines after 1 year include hepatitis B, typhoid, cholera, rabies if indicated. And 2 years after BMT, if no GVHT, the patients can take MMR, that is measles, mumps, rubella 1 dose. Also varicella, it is again optional vaccine, that all these vaccines can be taken only after consulting with a treating physician. But after completion of the vaccines, usually we do a testing for the vaccine response. The other important aspect usually is ignored is the sexual and fertility concerns. So the patients can resume sexual activity although the fertility is unlikely. They should use a barrier contraceptives for at least 1 year. Women can use lubricants, gels or other creams to relieve discomfort due to vaginal dryness. And also we tell them that they may experience, especially the women, may experience menstrual irregularities or menopause temporarily. And we also tell them women should have their usual gynecological examination. The miscellaneous aspects still, they are very important. One is dental follow. If any patient develops any dental problems, if they need dental procedures, it is indicated. If indicated, proceed for treatment only after obtaining opinion from the hematologist, as antibiotic coverage may be required. Eye checkup again is very important because the risk of developing cataract is high in post-TBI transplant patients after 1 to 2 years. So annual eye checkup is recommended. If patient has no GVHT, they are off immunosuppressant, after 1 year of post-transplant, they can go back for their employment. Also, the marriage also can be, they can go ahead. So what are the issues the children can have after the post-transplant? So children may experience long-term side effects after transplant. So they need to be monitored for growth and development, achievement of puberty, endocrine evaluation, especially children more than 10 years. And they may have changes in the dental development. So all these aspects should be informed to the parents. So they need to keep monitoring all these aspects during follow-up. So the children can go to the school after 1 year if they don't have any GVHT, no infection of immunosuppressant. So other problem is relapse or secondary malignancies. So they need to have, women especially can have annual gynecological examination. So where they can do pap smear, mammography, ultrasound breast, all these things will help us to detect the secondary malignancies early. So thyroid ultrasound, if patient has hyperthyroidism, dermatology opinion to rule out any cutaneous leukemia, and also if patient develops a relapse, they need to be treated either with chemotherapy or donor lymphocyte infusion or second transplant. The other problem is graft failure or rejection. So graft failure, generally what we notice after transplant during follow-up is secondary graft failure. Secondary graft failure is loss of donor cells after initial engraftment. So these are some of the causes where the recipient T cells and natural killer cells, and if they have any unnecessary antibodies in them, relapse can happen. Failure can happen. So also it is very common in HLA mismatched grafts, unrelated grafts, and reduced intensity conditioning. And also other cause could be ABO blood group mismatched transplants. So how do we really prevent graft failure? May be overcome by more intensified conditioning, increased cell dose, or more effective immunosuppression. So treatment, if at all they develop graft failure, cellular therapy with donor lymphocyte infusion and boost of donor stem cells without additional preparatory chemotherapy, or if these fails, retransplantation is another option. So psychological aspects, especially patients with graft failure. So patients will definitely experience disappointment, fear, anger, betrayal, grief, depression, and hopelessness. It is not only in patients, also in healthcare personnel who are involved in the patient's care may also feel a sense of failure and grief. So nurses should provide support and education on the diagnosis of graft failure, treatment options, and decisions regarding the care plan. All information must be individually tailored to the patient and family needs. Also, we can facilitate spiritual support if patient and family needs. So I'm happy to show these are some of the pictures of our transplant unit, stem cell transplant unit. You can see a patient in our unit. And this is the nurse station and the chemotherapy preparation area. Also in our center, we use UV treated water for external use of the patients, and also the water is filtered using head shower filter. So to conclude, allogenic HSCT is a complex procedure which poses great risk for the patients and has a significant impact in their quality of life. There is a tremendous role of hematology nurse in every phase of transplant process. This demands nurses to be highly up to date in their knowledge and clinical competence to ensure quality and safe patients' care. Thank you. I'm happy to take any questions.
Okay. Thank you, Ms. Lucas. So maybe we'll leave the question to the end. So the next talk is also a very interesting one because the difficulty in getting donor, and also just like one of the speakers mentioned about the COVID-19 situation, the arrangement for donor is difficult. So hepro transplant from the half match donor, like the parents, is getting more and more common. So the next speaker, Ms. Scarlett Ho, will share her experience on that from the nursing perspective. So Scarlett graduated from University of Sydney, Australia, and then get her master's degree from Hong Kong Polytechnic University. And then she became a fellow of pediatric nursing in 2012. And she has been trained in both Royal Marsden Hospital and also Toronto Sick Hospital. She has been engaging in pediatric oncology and bone marrow transplantation activity since her graduation after joining Queen Mary Hospital, and now she's with Hong Kong Children's Hospital. Scarlett, please. Yeah.
Hello. Good afternoon, ladies and gentlemen. Thank you for inviting me to share with you about the nursing role of selected T-cell depleted haploidentical HSCT in Hong Kong Children's Hospital. Before my presentation, I would like to introduce you about the Hong Kong Children's Hospital. Hong Kong Children's Hospital just started its inpatient service from March of 2019. It mainly takes care of children with a complex disease under tertiary care. We have pediatric oncology, nephrology, and cardiology, etc. So our pediatric oncology cases is all translocated from 5 regional hospitals since then. Just show you our HSCT center. We have 12 beds for active and post-transplant patients, all single room with HEPA filter, including 4 AIIR room for airborne infection isolation. Just come to the statistic of pediatric HSCT in our hospital. We have, since March 2019 to September of this year, we have done a total of 97 transplants with 71 allogeneic and 26 autologous transplants. For allogeneic transplants, for allogeneic transplants, we have done 35 haploidentical transplants since 2019. There is a drastically increase in haploidentical transplants. So look at the graph, just 9 months of this year, we have done 38 transplants together. So in fact, HSCT can be a curative procedure of a growing number of pediatric diseases, including malignancy, hematology disease, immunodeficiency disorder, and also metabolic disease, etc. When there is no actually matched siblings donor, nor unrelated matched donor, haploid related donors may be an option of choice. However, let me look at the distribution of our haploid transplant. We have done 35 haploidentical transplants with 29 patients, 6 patients with second transplant because of relapse, and most of them are ALL patients. Other than that, there are AML, lymphoma, SAA, thalassemia, neuroblastoma, etc. So, however, what we mostly concern in the increased incidence is the increased incidence of GvHD in haploidentical transplant. Also, the viral reactivation. So, in order to reduce the morbidity and mortality of these patients associated with GvHD, T-cell depletion has to be considered. There are various methods of T-cell depletion. It can be done in vivo or ex vivo. For in vivo, we can use anti-pharmacyte globulin or anti-CD52 monoclonal antibody, the alemtuzumab, as the conditional regimen for the patients. It is to remove the donor and recipient T cells to prevent graft rejection or GvHD. Also, we can consider post-transplant cyclophosphamide infusion in post-transplant day 3 and 4 in unmanipulated haploidentical transplants. It is the selectively depletion of proliferative alloreactive T cells while preserve the non-alloreactive T cells. For ex vivo, we use the kinemax system. There are positive selection and negative selection. We have done positive selection, this full immunomagnetic separation to select CD34 plus the hematopoietic stem cell and then give to the patient. However, the rest of the immune cells, it will be discarded. And the second negative selection we usually do here. There are CD3 plus and CD19 plus depletion, T cell receptor alpha beta plus and CD19 plus depletion, and also CD45RA depletion. All these can retain monocytes and natural killer cells in the graft. For our unit, we use mostly now is the T cell receptor alpha beta and CD45RA depletion. There are still pros and cons for T. The pros is decreased incidence of GvHD, decreased use of immunosuppressants, and decreased organ toxicity. And the cause of T cell depletion, it may be delayed immune reconstitution, reduced engraftment, increased disease relapse, and increased risk of EBV-associated lymphoproliferative disease and viral reactivation. So the nursing responsibility in having the T cell depleted haploid transplant, in fact, it is important to monitor the complications of transplant and also give early intervention. Also, in our setting, we will do the donor lymphocyte infusion for mixed chimerism or with severe viral infection. And also, we have to do adult donor apheresis So for the complication of HSCT, in fact, it is more or less similar for any kind of transplant. So like venous occlusive disease, transplant-associated thrombotic microangiopathy, angiography, virus reactivation, graft versus host disease, graft rejection, post-transplant lymphoproliferative disease, and slow recovery of the immune system. So this time, I would like to concentrate on the TATMA. The TATMA is a severe complication, has been increased awareness in recent years for both autologous and allogeneic HSCT included. It is an endothelial damage syndrome, which leading to apoptosis, leukocyte adhesion, activation of platelets, and thrombin formation, which gives significant morbidity or mortality. So multiple factors may associate with increasing risk of developing TMA, like the drug toxicity, use of calcineurin inhibitors, such as cyclosporine and sirolimus, and radiation, opportunistic infection, mismatched donor graft, and GHD. The diagnostic criteria for TATMA, first is the histology evidence of TMA on tissue sample, or 5 of the following diagnostic markers present. They are LDH above normal of age persistently, cystocytes on blood smear, thrombocytopenia with increased transfusion requirement, anemia or increased transfusion requirement, hypertension, proteinuria, and elevated soluble terminal complement complex activities. That is the plasma SC5B9, which is above normal. So the two highlighted proteinuria or elevated soluble terminal complement complex activity is considered if the 5 diagnostic markers, with one of them, the proteinuria or elevated soluble terminal complement complex, will be considered as the high-risk TATMA. So the clinical feature of TATMA is including thrombocytopenia, especially those with platelet transfusion refractory, elevated LDH, proteinuria, anemia, and falling hepatocarbon. TATMA triad have to be remembered. It is hypertension, thrombocytopenia, elevated LDH. For 3 of them happen together, you have to consider to monitor whether there is TATMA. Since the symptoms quite similar to other complications of transplant, it may be overlooked of this. So prevention and early detection is also important. So we have to close monitor of the blood count, calcineurin inhibitor level, LDH, and creatinine. Early evaluation of peripheral blood smear and other tests in those with rising level of the above. The treatment of high-risk TATMA, will be given eculizumab as a standard of care. For those not in high-risk group, it may receive supportive care. So the management for this is consider discontinuation of calcineurin inhibitor or dose reduction. Use alternative agents like MMF, corticosteroid, or azathioprine instead of cyclosporine, etc. And management of concurrent problems like infection, GHD, hepatic VOD. So the second, we come across a lot for T-cell depletion haploid transplants with donor lymphocyte infusion. It is an infusion of lymphocytes from the original stem cell donor to the recipient after allogeneic HSCT. It is expressed as the number of CD3 plus T lymphocytes per kilo of recipient of body weight. The indication for DLI with mixed chimerism with or without concurrent viral reactivation, and also post-transplant relapse of leukemia or emergence of MRD. So the initial dosage, it can be stepped up slowly. It is prescribed by the doctors. The low dose first we come to 2.5 times 10 to the power 4 CD3 per kilogram of the recipient. And then it can be stepped up to 1 times 10 to the power 6 and 1 times 10 to the power 7. So for DRI, we do at the bedside. So the doctor will calculate the dosage to be given, and then we have to liaise with the stem cell lab staff for boring and the cryopreserved lymphocytes. And it is transfused after boring immediately. The infusion of lymphocytes with premedication, and we have to close monitoring. We have to long-term monitoring, also monitor the episode of GHD. So number of DLI done in Hong Kong CH, we have total 17 patients have DLI, 57 episodes. 25 of them are fresh DLI and 32 are cryopreserved DLI. Those patients we have 1 to 12 DLI received in the past. So apheresis of adult donor, although we are in a children's hospital, because we have come across adult donors, we have to handle them and then do the apheresis for them. We have to do the donor workup, and then after choosing the appropriate donors, we have to start the GCS mobilization for 4 days. If for the poor mobilizer, we have to give Mosolvil. The target CD34 plus is 10 times 10 to the power 6 per kilo of recipient's body weight. We harvest the product. The harvested product will be undergo T-cell receptor alpha beta depletion and CD45RA depletion. The whole product, we take 9 out of 10 portion for alpha beta depletion and 1 out of 10 portion for 45RA depletion. We will cryopreserve the service-related DLI. So in conclusive, care of critically ill HSCT patients is full of challenges for us. Nurses have to have early recognition and intervention for the complications so that to improve the outcome of our patients. So intensive training is essential, and especially to update the advanced treatment periodically. So that's all for my presentation. Thank you.
I think because of the shortage of time, we may not have for questioning. But I would like to thank all the speakers for their contribution. Dr. Otip will close up on the session.
Okay. So thank you for all of the speakers and the topic of your presentation are very informative for our attendees. So I would like to, on behalf of the organizing of committee of the 26th Congress of Blood and Marrow Transplantation 2021. So we would like to thank all of the speaker and the chair, Godfrey, and also all attendees for the meeting. Thank you. Bye bye. สวัสดีค่ะ
Bye bye.
Bye bye.